Assalamu alaikum, everyone. My name is Ismail Abdullah, and I'll be giving you guys the last part of the crash course for the MID block. All right, so for this video, we will be covering 5 lectures. And throughout these 5 lectures, I'm going to sprinkle around a couple of MCQs and some case scenarios. So inshallah, we're going to start with fluid and body compartments, multi-organ dysfunction syndrome, hematological manifestations and systemic diseases, AI in medicine, and palliative care. All right. So this lecture is high yield, a lot of high yield concepts, honestly. I honestly expect a good number of MCQs that could pop from this one, inshallah. So let's start with a quick introduction. All right. When we're talking about fluids in the body, you need to understand the 60-40-20 rule, which is the body mass is made up of water 60%. 60% of it is made up of water, all right? 40% of these 60% is intracellular fluid. So it is within the cells. And it's very important that you know potassium is inside the cell, magnesium as well, and some organic phosphates. I'd only stress on potassium. And 20% is extracellular fluid, like sodium, chloride, bicarb, and albumin. And keep in mind that, you know, these fluids can transition throughout these compartments via, you know, osmosis, diffusion, active transport, starting forces. However, this is just an overview, okay? Now, how is the fluid composition in our body regulated? First of all, you'll have ADH, which is your antidiuretic hormone that's, you know, released in your posterior pituitary, and it responds to increased osmolarity, meaning increased, you know, concentration in the body of the solutes, meaning, you know, we have less water, so it's going to promote your water reabsorption. Okay, means that you're going to have less urine output, for example. Okay, so this is number one, ADH. Second of all comes the RAS. RAS is activated by hypotension, low perfusion, all right? Low perfusion in your you know, in your vasculature. So it's going to promote your sodium and water retention, all right? Then you have the AMP, atrial natriuretic peptide, released from the atria and the ventricles when they are overly stretched, you know? So this will promote sodium and water excretion to reduce the blood volume. Because, you know, in stretched, you have this high volume. So it kind of tells the body that, all right, we're having, you know, a lot of volume that we probably don't need, and it's going to overwork us. So let's just get rid of it. And lastly, the thirst mechanism. So when you're just thirsty, you go and like chug on some fluids. The thirst mechanism is triggered by the increased osmolarity and decreased volume, okay? So it's like a balance. And if the balance breaks, you could either have hypervolemia or hypovolemia. Okay, why would we have hypervolemia? Why would the body reach a state where, you know, it's going to lose its control and just, you know, store a lot of water or a lot of fluids, say. This is because the checkpoints are going to fail. Who are your checkpoints? Your heart and your kidneys, right? So these regulation mechanisms, you know, are kind of become, you know, fail to work. Like, for example, the RAS is in the kidneys, you know, the AMP is in the heart. So when the checkpoints fail, when you have heart failure, kidney failure, you're going to have hypervolemia. So it's going to look like edema. It's going to look like dyspnea. Why dyspnea? Because, you know, when they lay down, the pulmonary edema, the fluids building up in their lungs, is going to make them be short of breath. So they're going to have dyspnea. You can even hear crackles. You can even have jugular venous distension, all right, and weight gain. So these are very important, you know, clinical signs that you can pick up in scenarios. Now, hypovolemia is going to happen when we're basically excreting a lot of fluids, all right, out of the body. And this happens when you vomit, when you're having diarrhea, when you're losing a lot of blood, even seen in burned patients, okay, and even diuretic abuse. People who abuse diuretics usually come in with hypovolemia as well and other important findings. So they're going to present with tachycardia, hypotension, dry mucosa, azotemia, all right, because in a hypovolemic state, you don't want to lose any fluids, so they're going to have azotemia, okay, and confusion, of course. So now let's focus on the part where I need to give patients fluids, all right? Before I do that, I need to ask myself, what type of fluid do I need to give? Is it because I want to fix an electrolyte imbalance, or is it because I just want to give fluids because the patient, has been losing a lot of fluids, like for example, in hemorrhage, right? And the rate of replacement, and I also need to look at the patient's outcomes. Is he improving or not? And the total fluid, all right, the total fluid that you need to give to the patient should be composed of three different factors. First of all, how much in deficit is he in? Second of all, how much you need to give him so that he can maintain, that state of, euvolemia in his body, and what are the ongoing losses, right? Like, let's say, for example, a patient is, bleeding, okay, and let's say he bled around 500 milliliters of blood. So this is something you need to give. Let's say you need to maintain it with, let's say, for example, 100, all right? And then let's say there are some ongoing losses going on of around 200. So you need to add all of these up, and this is the total amount of fluid that you need to be giving the patient, within a variable amount of time, okay? Now, the type of fluids that we will cover during this crash course are those on the screen. We have more, but this is what we're going to be limited to. So we're going to start off with crystalloids, okay? Crystalloids are type of fluids that are isotonic, meaning that their osmolarity is, and the concentration of the electrolytes, if they had any, are going to be, similar to the plasma. Okay, so we have three. We have the normal saline, we have lactated ringer, and we have the dextrose in water. Okay, and lastly, we have colloids. Colloids are usually high molecular fluids. They have albumins. We give them when patients are, having hypoalbuminemia, for example. So yeah, and of course, they could even be given in patients who are burnt. We're going to go through all this, inshallah. So crystalloids are your first line when it comes to resuscitating a patient, and maintaining and correcting their electrolytes, okay? So, this is our first clinical scenario. So we have a patient who presents to you in the emergency with severe hypovolemia shock following 2 days of intractable vomiting and diarrhea with an initial serum sodium of 132. What am I going to give this patient? I'm going to go give this patient normal saline, okay? Why normal saline? Because first of all, he's in a hypovolemic shock. We go to the ABCs, okay? His airway is, let's say, fine. His breathing is fine. His circulation is failing, right? So this is where I intervene and I resuscitate the patient by giving him crystalloid. And the best one that you're going to give is going to be normal saline. You'll give it when they're having, when you need to provide extracellular fluid resuscitation, when they're having shock, hemorrhage, severe vomiting and diarrhea, metabolic alkalosis, and hyponatremia. This is your, choice. So this is another patient. A 35-year-old trauma patient arrives to the emergency with a 35% total body surface area, partial thickness burns, requiring aggressive volume resuscitation via the Parkland formula. What are we going to give him? We're going to give him lactated ringer. Now, why do we give lactated ringer? First of all, we need the patient is not stable, so we need to give crystalloids as our first line of resuscitation. Tamam. And this is an acute scenario, so this is going to be an acute fluid resuscitation, so I'm going to give him a lactated ringer. Okay, why do we give lactated ringer and not normal saline? Because this one is considered one of the balanced crystalloids. Why? Because it mimics the physiological plasma parameters of the human very closely. So we give it to them, all right? We give it to patients also who have trauma, major burns, intraoperative fluid replacements, all right? However, I'd avoid giving a lactated ringer to patients with severe liver disease, okay? Now, if this patient happened, they report that, let's say he got stabilized, but however, he has very, very low levels of albumin, then I'm going to give him a colloid, okay? So this is an elderly obtunded nursing home resident, admitted with severe, profound hypernatremia, all right, due to water deprivation. Okay, so basically what happened here is that, he's been not drinking enough water. Okay, he's being neglected either by himself or by the nursing home. And what happened is that the concentration, of the sodium just happened to be more prominent, in the blood, given that the water, levels decreased. So the solutes are going to now look more concentrated. So this is what really happened. What am I going to give this patient? What do you think? We're going to give him dextrose. Why do I give dextrose? I give dextrose because this is just, glucose, right, in an isotonic bag, okay? Has no electrolytes. So it functions like, isotonic fluid. But once we infuse it, what happens is that the body is going to rapidly metabolize the dextrose, leaving behind all the free water, okay? And because of that, what's going to happen to this hypernatremia is it's going to get diluted, okay? So this is what it really try to do, okay? Try to provide water, fully to the body so that it can dilute and correct this electrolyte imbalance, okay? So never give dextrose to hypertensive or septic patients because this will not really expand their intravascular volume, all right? So just keep that in mind. Now, if we have a patient who's hypernatremic and hypotensive, what am I going to give first? So think about the ABCs, right? He's hypotensive, so his circulation is impaired. So I'm going to give normal saline first, all right? And if his hypernatremia persisted, then I can introduce dextrose later on after the patient is stabilized. Okay, so something about these lectures that I'm going to be giving today, inshallah, for your clinical years, it's very important that you look at the whole picture and always go back to the basics. It's going to really help you a lot. I know sometimes cases could get complex, but always go back to the basics. Really is going to put your mind at ease. So this is a cirrhotic patient with tense ascites, undergoes a large volume therapeutic paracentesis where 6 liters of fluid are drained, requiring oncotic support to prevent post-paracentesis circulatory dysfunction. What am I going to give this patient? So think about it. He needs an oncotic support, right? What would I give him? I would give him a colloid. Why colloid? Because colloid is going to help, in the volume expansion, all right, given that it has, it contains albumin, okay? So, yeah. Now, moving on to sodium imbalances. So we have hyponatremia and hypernatremia. So I like to put it here in a table where it's just all in one slide and it can help you. So when we say hyponatremia, it's basically anything less than 135. Hypernatremia is anything more than 145. Anything in between is considered normal. So when will I have hyponatremia? I'll have hyponatremia when there's basically a lot of water relative to the sodium levels. So it's just like too diluted. And when would this happen? This would happen when we have hypervolemic states. Remember the checkpoints that we mentioned? So, for example, you could be having heart failure. So this is sometimes when it can happen. Sometimes you can have inappropriate, release of ADH. So you're basically going to have a lot of water retention in the body. So this is also sometimes, you can have masked hyponatremia, right? Excessive water intake, or even thiazide diuretics. Why thiazide diuretics? Because it's going to let go of the sodium. all right? So these are the common causes of why you could have hyponatremia. Now, what happens is that when you're having a lot of water, the water is going to move into the cell, causing this cellular swelling. So if I treat hyponatremia too quickly, what could happen? I could get something we call osmotic demyelination syndrome. And you've probably heard something called as the locked-in syndrome. So when you treat it too fast, you are putting the brainstem at risk of demyelination, okay? So this is something very important that you need to keep in mind when managing a hyponatremic patient. And then the patient could end up having locked-in syndrome. Hypernatremia, on the other hand, and it was when you have little water compared to the sodium levels. And this could be seen in dehydration or in people who excessively sweat, or in people who have, ongoing severe diarrhea, or they could be having diabetes insipidus. Okay, here the water is going to move out of the cell, causing cellular shrinking. So here I'm going to rehydrate a patient normally, but if you hydrate too quickly, you are putting the patient at a risk of cerebral edema, because when you're just giving a lot of water to these shrink cells, the water is going to move into the cell, and if you do it too quickly, it might cause the edema, okay? Now, when I need to treat hyponatremia, I need to classify it, all right? And I classify based on, the volemic state. So is it hypo or hypervolemic? So when we say hypovolemic, it actually means that both water and sodium are low. However, sodium, takes the upper hand. If it's euvolemic, means that the total, all right, the total body sodium, is normal with increased total body water, okay? Just like we see in, inappropriate ADH release, okay? Hypervolemic will be increase in the total body sodium with a massive increase in total body water. And this could be seen, when our checkpoints get to fail, like congestive heart failure or nephrotic syndrome, okay? So if we're having hypovolemic hyponatremia, I'm going to give this patient IV saline, okay? Because I need to restore the volume. And maybe after restoring the volume, I'm going to have, probably restored sodium. If not, then we can give to fix the electrolytes. Euvolemic hyponatremia, here, I know for a fact that, the water in the body is a lot, all right? So what I'm going to do is I'm going to put this patient on fluid restrictions, and we can give them salt tablets, okay? Hypervolemic hyponatremia, here again, a lot of fluid. So what I'm going to do is I'm going to give the patient fluid restrictions and diuretics, okay? Severe hyponatremia with seizure, here I'm going to give a 3% hypertonic saline of 100 to 150 milliliter bolus. Now, I didn't explain this one, right? Because it's out of your scope and this is a crash course, but just remember it. In case you see a patient who has really, really low sodium levels and he is seizing, then your choice is going to be to give him a 3% hypertonic saline, okay? So you can restore the sodium levels. So now let's talk about potassium imbalances. Now, potassium imbalances, we have hypokalemia and hyperkalemia. The management of these imbalances are extremely high yield, and we're going to cover them, inshallah. So let's start with hypokalemia. So when I say a patient is hypokalemic, I mean to say that they're having, potassium levels less than 3.5. So why am I worried? Why am I worried if my potassium levels get to drop? Because when they drop, it will hyperpolarize the cell, making it more difficult to wake up, more difficult to actually, for it to, have an actual potential and all that, right? So it's going to make it less excitable. Now, when would such scenarios happen? It could happen when you're having severe vomiting and diarrhea, okay, because you're losing the potassium. When you're having renal losses. So, for example, people who use loop diuretics, thiazides, or if they have hyperaldosteronism, aldosterone would push for losing the potassium. So in such scenarios, they can have hypokalemia. Or if, it could just happen to have that this potassium gets to be shifted intracellularly, okay? And this happens in insulin, right? When you give patient insulin, okay, like for example, which we're going to discuss inshallah in hyperkalemia management, one of the lines is you'd give them insulin so that it could be shifted intracellularly, okay? So how would a patient who has hypokalemia present to you? He's going to present with muscle weakness, cramps, hyporeflexia, and ileus. Okay. If they were hyperkalemic, on the other hand, they will present to you with ascending paralysis and paresthesia. They're going to have numbing all over, all right, as well as muscle weakness, but they're not going to have hyporeflexia. Now, when you are hyperkalemic, meaning that you have your potassium levels more than 5, this will depolarize the cell, bringing it closer to the threshold, right? But however, it's going to reach a point where it plateaus and inactivates these sodium channels, so it will decrease your excitability. So in both cases, it decreases excitability. However, one will hyperpolarize, one will depolarize it too close to the threshold, that with time, it's going to inactivate these sodium channels, decreasing the excitability. When will I see hyperkalemia? I can see it, first of all, in renal failure, okay? Because, you'll have injury to the kidney. You're not going to lose, the whatever extra potassium you have. That's one. Second thing, you'll see it in medications. People who use ACE inhibitors, people who use ARBs, people who use spirulactones like potassium-sparing diuretics, even NSAIDs, chronic use of NSAIDs. You'll also see it when, your muscles break down, like rhabdomyolysis, for example. Another very common hematological manifestation is tumor lysis syndrome in patients who have lymphomas, for example. When you aggressively treat it, you're going to have something called tumor lysis syndrome, and basically it's just you breaking down this tissue, and all of these, potassium, magnesium, sodium are all going to be out. So it could cause hyperkalemia, okay? Or a cellular shift, during acidosis. All right. So basically, the takeaway from this slide, you need to know the definition, okay, and you need to know what are the causes and how is it going to present. Now, something that's very important, okay, which is, in my opinion, is more important than the initial slide, is you picking it up on an ECG. Because sometimes what a question will do, it will either give you an ECG, I hope not, or they're going to describe the ECG for you. So if they happen to tell you that their T wave is peaked, all right, and their PR is prolonged, okay, the PR is prolonged and the T wave is peaked, and the base of the QRS is widened, then this is in favor of hyperkalemia. On the other hand, if your T wave is flattened, then that's hypokalemia. I usually just remember the T wave part, okay, T wave and the PR. That's it, honestly. I think that's more than enough, hopefully. So yeah, this is how you differentiate hyperkalemia from hyperkalemia on an ECG, okay? Now, this is extremely important. Doctor highly emphasized on how are you going to manage hyperkalemia. Hyperkalemia, first of all, when you want to manage, it's an emergency, okay? And I've seen it in the emergency department. It's an emergency. You have to manage it immediately, okay? Because you're putting the patient at a cardiovascular risk. So what you're going to do is, first of all, you need to relieve their neuromuscular symptoms. So you're going to give them an IV calcium gluconate. Then, I know that I have a lot of potassium ongoing in the blood right now. I need to shift it intracellularly. So I'm going to give these patients insulin, okay? Then I need to eliminate this potassium from the body now. Then here I'll probably give them loop diuretics, or you can give them things that would bind to potassium, like patrober. So this works in the gut. It will bind to the potassium. It's just going to leave your body. Okay, it's very important. So again, IV calcium gluconate, so you can relieve their symptoms, then insulin to shift the potassium intracellularly, and then you give loop diuretics or potassium binders so it could bind and eliminate the potassium from the body. Okay. Now, for hypokalemia, there's no much emphasis from the doctor. However, I just put this here for your reference. If it was between mild and moderate, I'd give, potassium supplements orally. If it was severe, then I'm going to move to IV, right? However, if it's refractory and it's not, improving, the levels are still low, then usually we give magnesium, okay? Because it's seen that in magnesium deficiency, you're going to have potassium deficiency, okay? Now, calcium imbalances. So again, hypocalcemia, hypercalcemia, these are the levels that you guys need to know. If ionized calcium was less than 4.65, it's considered hypocalcemia. If it was more than 5.25, it's considered hypercalcemia. How would you know? Okay. Honestly, I find this one to be one of the easiest ways that you can actually pick up, the calcium imbalances. So for hypocalcemia, right, you're having hyperexcitability, right? Because, when you're having low calcium, you are basically lowering the threshold for the sodium channel activation. So it's going to be more easier for these neurons to pick up an action potential. So they're going to fire simultaneously that, the patient will present with tetany, okay? That, they can have some sort of like also muscle spasm. They will also have carpopedal spasm. They can also have paresthesia and hyperreflexia, okay? Like, when do I see it? Number one, you'll see it in hypoparathyroidism. Usually, it will tell you like a scenario that a patient had, let's say, some thyroid pathology, and they had to go in and surgically remove it. Usually, all right, 90% of the time, they're going to remove the parathyroid with it. And this is when you'll have hypoparathyroidism. Or could be seen in vitamin D deficiency, hyperphosphatemia, or even in acute pancreatitis. Like, yep. Hypercalcemia, usually you'll see it in primary hyperparathyroidism, right? And they present with, this very famous mnemonic: stones, bones, groans, thrones, and psychiatric overtones. They're going to have kidney stones made of calcium. They're going to have pain in their bones because, of this rapid breaking of the bones and releasing all the calcium. They're going to have groans. They're going to have a lot of pain. They're going to have frequent urination. And, they could also have, some psychiatric involvement. Okay. Now, what really happens? Exactly the opposite from what hypocalcemia does. Here, you're going to have depressed excitability. Okay, so we raise the threshold, right, for the sodium channels to be activated, making it harder for the nerves to actually be depolarized. All right. So this is what you really need to pick up from this slide. Now, these are just signs. We have the Schwastek sign. So in a hypocalcemic patient, if you just try to, just touch their cheek, they're going to, like retract it in a way. So that's what we call the Schwastek sign. And the Trousseau sign is basically that you'll start having carpal pedal spasm when you, when you put the BP cuff inflation for for 3 minutes. They're going to start to have spasm. This is what we call Trousseau sign. So usually they're going to describe this to you in questions, or they're just going to probably tell you like in an SAQ, a patient who has hypocalcemia, what are you expected to see on their physical examination? You're expected to say tetany, Trousseau sign, Schwastek sign, carpal pedal spasm, these kind of things. Okay. Now, again, ECG changes. All right, very important that you know. So what can you notice here? You can notice that in hypocalcemia, you have, a QT prolongation. All right, and in hypercalcemia, you can see that there's QT shortening, right? So a patient who has, I think this is more important for hypocalcemia, that, a patient who has hypocalcemia is at a higher risk of QT prolongation. So they could have torsade de pointes, okay? It's very important that, you try to link those. Now, acid-base disturbances, the doctor didn't really stress on it. He said that he needed an entire lecture to explain this. I'm just going to give a quick tip on how to approach an acid-base disorder question. Your very first thing that you need to lay your eyes on is the pH, okay? So let's say we're dealing with a low pH, right? Now, I'm going to look at the carbon dioxide levels and the bicarbs to see which one is really, accompanied with, and it could explain why the patient is having low pH, like an acidic pH, and see what is compensating for the low pH. So low pH, right? So when it's acidic, I'm expected to see what? I'm expected to see either high levels of carbon dioxide or low levels of bicarb, right? So here I look at the bicarb and it's actually low. So now I understood that it is metabolic acidosis, right? And here I can see that, my carbon dioxide is actually also low, try to compensate for the, acidic, metabolic acidosis. So usually patients will be hyperventilating, okay? Explains why the carbon dioxide concentration is going to be really low. So in metabolic alkalosis, your pH is going to be high, right? It's going to be alkaline, of course. And then again, I look what is really associated with it. So when it's alkalosis, when it's high pH, I'm expected to see two things. Either I'm expected to see low carbon dioxide or high bicarb, right? So here I have to have a high bicarb, sorry. Okay, so your levels of CO2 to compensate for the metabolic alkalosis are going to be high. So you're going to have hypoventilation. And one other thing that I'd also love to appreciate in metabolic disorders, in acid-base disturbances, all the arrows point toward the same direction. Just makes it easy for you, just in case you get these hectic arrow questions, all right? So now when it's respiratory acidosis, your pH is going to be low again, but then I need to figure it out. Who is, causing this pH to be low? And here it happens to be that you have high carbon dioxide, so it's making it more acidic. So it's respiratory acidosis. And to compensate for, this disturbance, your bicarb levels are going to be high, okay? And for respiratory alkalosis, same thing. High pH, and then you're going to have low carbon dioxide, and then you're going to have basically low levels of bicarb in your body to compensate for the respiratory alkalosis. I hope this is simple. I hope it's easy. I hope I didn't, overdo it. So now we have just a couple of questions before we proceed to the other lecture. So you have a 60-year-old woman with 3-day vomiting and diarrhea. Her sodium levels are 150. Her blood pressure is 78/42. What is the most appropriate initial IV fluid? So I'm going to give you 3 seconds. So it's going to be normal saline. Why? Because she's hypotensive. Before she's hypernatremic, she's hypotensive. So I'm going to give her normal saline first. Okay. So this is a patient with heart failure. Sodium is at 129. He has edema, elevated GP, bilateral crackles. What is the most appropriate management for his hyponatremia? Would I give a normal saline? Am I going to give vasopressin antagonist, fluid restriction and diuretic, or 3% hypertonic saline? It's going to be fluid restriction and diuretic. Why? Because he's having hypervolemia, right? He's having cardiac failure. He's having hypervolemia, hyponatremia. I'm going to give him fluid restrictions and diuretic. Okay. So this is a patient. His potassium levels are 6.9, peaked T wave, okay, and widened QRS on ECG. Which intervention should be given first? So remember, we have 3 tiers that we need to cover. So what's the first thing that we do? Calcium gluconate, and then insulin, and then we give some things that would eliminate the potassium from the body, like potassium binders or loop diuretics. Okay. This one is a 45-year-old post-bowel surgery patient, NPO for 5 days on dextrose only. He developed muscle weakness, irregular heart rhythm. His potassium is low. His magnesium, I think, is also considered low. What is the primary cause? Is it excess urinary potassium loss from surgery? Is it because the dextrose has no electrolytes? Is it because he happened to develop SIDH from post-surgical ADH release, or he suffered a renal tubular acidosis from anesthesia? What do you think? It's going to be B. Why B? Because dextrose, as I told you, has absolutely no electrolytes. It only provides free water, so it could dilute, whatever electrolyte that happens to be concentrated, right? A patient who's NPO and is on dextrose will develop hypokalemia, magnesemia, and hypophosphatemia. Okay, so what do we do here? I give him something that's balanced, right? I give a balanced either crystalloid, so I can give him like lactated ringer, I can give Plasmalite, something that would include electrolytes. Okay, all the other options are wrong. Now, moving on to multi-organ dysfunction syndrome. Honestly, this lecture is basically a cascade that you need to understand. Every organ follows the same pattern. It's just that you need to understand it in its own context. And at the end, there's a criteria that we use to evaluate patients, evaluate their organ failures, and what kind of protocols that we need to put them on depending on the score. Okay. It's not really a difficult lecture, inshallah. So what is MODS? MODS is basically when you have a progressive failure of 2 or more organ systems due to dysregulated inflammatory response, due to a clinical insult like trauma, burn, shock, or infection. So they all follow the same cascade due to a dysregulated inflammatory response. Okay, you need to keep that in mind. So let's take a look at this cascade. Okay, so if you understand this, inshallah, everything else that I'm going to cover within the next 5 to 6 slides are going to be really, really easy. So first, you get your initial insult, all right? And this insult is going to trigger an inflammatory response. And it's, of course, going to be systemic. Here you have the cytokine release, okay, which will disrupt the endothelial system. So you're going to get some endothelial injury, which will lead to, vascular permeability increasing, which will lead to edema as well, and is going to lead to microcirculatory failure. Why? Because with this edema and increasing in vascular permeability, you're going to have impaired oxygen delivery to tissues that require oxygen. Then, because now you're in an ischemic situation, you're going to have cellular dysfunction. Your mitochondria will start to fail. Your cells are going to start, having apoptosis, and you're going to reach this multi-organ dysfunction. Again, the cutoff is 2 organs, 2 or more. Okay. So first of all, cardiovascular. So let's say a patient who's having a cardiogenic shock. They're going to present with a cold, pale, cyanotic skin, distended neck veins, altered mental status, hypotensive, shock. Why? Because first of all, systemic inflammatory response, they're going to have the cytokine storm, usually when it's inflammation. These are the 3 ones that you need to remember: TNF alpha, interleukin 1, interleukin 6, is going to cause this nitric oxide to be increased, causing vasodilation, like mass vasodilation all over. It's also going to depress the myocardial muscles, causing them to lose contractility, causing them to lose their vascular tone, right? And then they're going to have refractory hypotension. And what defines refractory hypotension? When your mean arterial pressure is less than 65 despite all fluid interventions. And this will lead to tissue hyperperfusion, causing ischemia. So did you see there's a pattern where you have basically an inflammatory response. Okay, it's going to disrupt how blood reaches, the tissues of that organ. It's also going to disrupt the function, of that organ. And then because of the ischemia, you're basically going to have this hypoperfusion, which will lead to the organ's death. Okay. So it's just a pattern. Just change the organ. Let's say lung, same thing. Kidneys, same thing. It all follows the same pattern. So here, in a patient who basically has this cardiogenic shock, I put the symptoms up here for you. Your target is that you need to bring up his mean arterial pressure. So I'm going to give him norepi as his first line. Second thing, I'm going to give him a vasopressin to, fix the hypotension that he has. Because he has, less contractility. Here, I'm going to give him inotropes, right? Um, and then to improve the vascular responsiveness to the medications that we're giving in such refractory cases, we can give corticosteroids, okay? Now, same thing happens, in the lungs. A patient's going to present with extreme shallow breaths. He's going to have low blood pressure. He's going to be confused. His X-ray is going to show bilateral infiltrates. Like, again, same thing. What's going to happen? A lot of inflammatory response can happen. Dysregulated, he could have a cytokine storm. Okay, or here, for example, he could be having a neutrophil-mediated damage to his endothelium, which will lead to his alveoli capillary barrier to break, causing pulmonary edema, which will cause the crackles, the dyspnea, shortness of breath, impairing gas exchange. So now he's going to have, a VQ mismatch, less oxygen entering the blood, right? So he's going to have an acute respiratory distress syndrome. How do we define the acute respiratory distress syndrome? We have basically a ratio, okay? A ratio that we follow, which is basically, arterial oxygen, all right, over the inspired oxygen level. And when it's less than 300, okay, here it's basically the beginning of an acute respiratory distress syndrome. So what is this ratio? It's usually called the P to F ratio. What does it tell us? This ratio basically tells us how efficiently do the lungs transfer oxygen from the alveolar sac into our bloodstreams. So if it starts to decrease, meaning that the patient is in a distressed, his lungs are in a distressed situation. So if it's, if it happens to drop to less than 200, that's going to be, mild ARDS. If it happens to be less than 100, then that's severe ARDS. I didn't put it here. I'm just mentioning to you guys just for the sake of completion. Okay, so here, I want to make sure that I correct the VQ mismatch by making sure that the patient is getting enough proper ventilation. So you either can give him a high flow nasal oxygen, so that's mechanical. You can, or try to give some sort of, as long as it's protective to the lungs, okay, because sometimes some sort of breaths could cause some sort of injury, okay. And if the patient was not responding, then we can do an ECMO, okay, which is basically extra corporeal support, okay. So basically, the takeaway from this slide is basically you just need to pick up that the patient is actually having ARDS and how does it happen. So usually due to pulmonary edema that happens secondary to the alveolar capillary barrier, basically breaking due to neutrophil mediated damage. Easy. Renal. So a patient was going to present to you with oliguria or anuria, even like no urination the past 24, 48 hours with rising creatinine levels. Okay. So here, of course, you're going to basically let the patient undergo dialysis as some sort of management. Okay. And you need to understand that early initiation of dialysis do not necessarily improve the outcomes. Okay, you need to wait for a clear indication that this patient actually needs, dialysis. Is he hyperkalemic? Is he uremic? Or is he, for example, having some sort of refractory acidosis? Okay, he's not responding to medications. This is when you put him on dialysis. But that's not your initial step. Oh, خلاص, the patient is having AKI, yalla. Let's put him on dialysis. Okay. So this is basically how it also looks, right? So you have the systemic hyperperfusion that happens that will decrease the blood flow to the kidneys, which will lead to ischemia within the tubules, which will also attract inflammation, right? And necrosis, which will lead to the kidney injury, letting us have oliguria. Now, for your CNS, right? Basically, what would happen is basically your blood barrier getting disrupted. And if that barrier gets disrupted, it's like all hell broke loose. So what happens here is basically, it's going to impair the ability of the cerebrum to auto-regulate its vascularity and all that. And it's basically you're going to attract oxidative stress, to the tissue. So you're going to have this ongoing neuroinflammation, which will lead to septic encephalopathy, right? Meaning that basically you have some sort of pathogen that's infecting and inflaming your your brain tissue. The patient is going to present to you with altered consciousness, delirium, confusion. Here, how do you assess it? It's very important that you know that you assess it with the Glasgow Coma Scale, GCS, and the score is out of 15. Okay. Now, for hematological purposes, you want to look at DIC. Okay. Basically when you have blood clots all over your body. So again, we start with our endothelium getting injured, and you have tissue factor being released. Tissue factor, if you remember from Hem-Onc, it will basically activate your coagulation cascade. So now you're going to get thrombin generating, you're going to get fibrin depositing as well. And this will cause microvascular thrombosis, right? This microvascular thrombosis could actually trap these small mini arteries, that will lead to organ ischemia, okay? And then you'll have the patient presenting to you with DIC and thrombocytopenia. You need to understand, in DIC, the patient will bleed and clot at the same time, okay? He's clotting because, due to coagulation cascade, but you're taking up all the coagulation factors, so the patient will start to bleed. So they bleed and clot at the same time. Okay. Now, the SOFA criteria, it's basically we want to assess the organ failure that's happening in the body. So what you're going to do here is that you're going to score the 6 different organ systems, each out of 4, with a total of 24. If your SOFA happens to increase by 2 points, it immediately suggests that the patient is having some sort of organ dysfunction. The higher the score, the higher is your mortality rate. And if the score happens to be more than 11, the patient is at 90% chance of dying, And one score that you just pick up is not really as significant as having a track, of different scores, and keep a trend to see is the patient's situation getting better or declining. If their score happens to decrease and they're improving, just continue your care. You're doing your absolute best job. If their score is happening to increase and their outcomes are deteriorating, then here we need to escalate the care and make it more advanced. So this is really all about MODS. Very simple, very easy. Now we move to hematological manifestations of systemic disease. Honestly, within this lecture, I was not able to pick up a single theme. But what I was able to understand is that you're probably guys are going to get questions where they tell you, for example, a certain lab representation of a certain disease, or an organism that causes a certain disease, and they're going to tell you to figure it out. Okay, it's hectic, but inshallah we're going to make it easy. So now let's start with the most high yield concept. It's going to show up in your step 1, it's going to show up in your step 2, it's going to show up in your 4th and 5th year. It's called anemia of chronic disease. Okay. Now, I want you to pay attention to this slide. It really explains it all. Okay. These are basically just some bullet points for your reference. So, when you have a disease, initially, there's some sort of inflammation is going to happen. Okay. No matter what the disease is, even if it was cancerous, okay, you're going to have some sort of inflammation. Then, chronically, you could have anemia, right? How does it happen? So when chronic disease, with this ongoing long infection or certain condition, you're going to have this release of inflammatory cytokines that happens, at a dysregulated rhythm. So you're going to have interleukin-1, interleukin-6, and TNF-alpha. And the biggest player that you have to remember and never forget is interleukin-6. Why? Because interleukin-6 is going to deliver and tell the liver, yalla, I need hepcidin. And if you remember from first year, hepcidin is going to cause what? Is going to decrease absorption of iron, right, in the guts, right? And basically, here's exactly what happens. Your hepcidin will inhibit iron transporter proteins on macrophages and enterocyte. So now you're going to have less release of iron from macrophages. So now if you take a macrophage and put it under a slide, you'll find that there's a lot of iron within it, okay, due to hepcidin. So less release and less absorption from the gut. This will cause less heme synthesis because, we need iron to make hemoglobin, to make red blood cells. So now you're going to have less heme synthesis, okay? And because now you have less heme synthesis, you're going to have less erythropoiesis, right? And with that, you're going to have something we call normocytic anemia. It's going to be normochromic normocytic anemia, okay? طيب. Now, also on the sides, you guys need to keep in mind that erythropoietin levels are going to decrease, right? Because these inflammatory cytokines are going to go to the kidney and cause less production of erythropoietin. And at the same time, there will be less response of the bone marrow to erythropoietin because aslan, you're going to have low erythropoietin levels, okay? And less erythropoiesis. So it's actually like balanced from all places that I have less production of this and I have less need for this because it's hindering the entire process of producing, heme and making red blood cells, okay? Like, however, you need to keep in mind that no matter what levels it reach, still it will have some sort of sufficient levels of iron to make, RBCs at whatever amounts of hemoglobin available. Okay, this is why it's going to be normocytic. Okay. Now, what I really needed to take all from this slide, I want you to understand it's going to be normocytic normochromic anemia. So if they get you an MCQ or an SAQ, remember normochromic normocytic. Interleukin 6 is the imposter here. It's the one behind this big play. It's going to induce hepcidin production, right? And it's also going to cause the cascade to start. It will inactivate your iron channels on your enterocytes and the macrophages, leading to less absorption and less release of the iron, okay? Now, this one is from my step one. It's very important that you guys be able to differentiate between iron deficiency anemia and anemia of chronic disease. Ferritin level in your iron deficiency is going to be low. In anemia of chronic disease is going to be normal or even high. Why? Because ferritin, ferritin gets to be released, during inflammatory responses. Okay, so you need to keep that in mind. The mean corpuscular volume could be normal because again, we're still having appropriate hemoglobin, we're still having whatever iron available, and we're still using it. Okay, it's going to be normal. The transferrin, the total iron binding capacity, here is going to increase. Here is going to be, it's going to stay normal or decrease. Okay, so basically these are the three most important ones that I'm going to probably you guys could pop a question with, and these are the ones that where you're actually maybe get asked about. Okay, something else that you guys want to refer to is also your C-reactive protein and the serum cytokines. It's of course going to be peaked in anemia of chronic disease because it's an ongoing inflammation or ongoing condition, right, in the body. So of course you're going to have high CRPs, you're going to have high cytokines. Okay. Now, this is anemia of chronic disease. Inshallah, it's easy peasy. Now let's move to SLE. Now, I thought it would be not nice to not introduce this disease before talking about their hematological manifestations. So SLE is a condition where you basically have certain antibodies in the body that happen to be positive. So you have ANA, you have anti-DSNA, and you have anti-Smith. Okay. It's very important. Usually they come the question all in together. Okay. A patient usually is going to come with this beautiful malar rash on their face, easy, like classical sign. All right. They could also have oral ulcers. They could have some sort of joint arthritis, photosensitivity. Okay. And here we're going to talk about their blood disorders. All right. Now, a patient that happen to have SLE. SLE is a chronic condition, stays there for a long time, right? They will have anemia. Okay. Why could they have anemia? They could have anemia due to, this autoimmune, hemolytic anemia, where basically they're just going there and attacking all these red blood cells. Okay, you need to keep that in mind. That's one. Second, they could have leukopenia. Why leukopenia? Because they could have anti-lymphocyte and antibodies in some cases. Okay, they will have reduced T cell count, right? They're going to have thrombocytopenia, right? And they could also sometimes have something what we call lupus anticoagulant or antiphospholipid syndrome. Okay, this is basically going to precipitate thrombosis, all right, in the veins, is also going to cause miscarriages. So usually a question will be like, usually a 23-year-old female, like a young female, all right, and she had, consecutive 2 to 3 miscarriages, right? And she's basically trying to be pregnant. That's antiphospholipid syndrome. And sometimes it could be under the umbrella of SLE. Okay. So it's important to pick it up. So usually how will they ask you? They'll basically give you a clinical scenario which you need to figure that it's SLE. They could tell you what could this patient have, or how could her lab results turn back. She will have anemia, she's going to have leukopenia, thrombocytopenia, basically everything is going to be low. Okay. And she could have antiphospholipid syndrome. And if she had antiphospholipid syndrome, it's going to tell you in the questions that she's having these miscarriages and spontaneous abortions. Next up is juvenile idiopathic arthritis or rheumatoid arthritis. Here, this is a very, very classical scenario of this ongoing inflammation that happens chronically. So it fits the anemia of chronic disease, right? So the patient could have anemia. That's one. Second of all, because they're having arthritis, joint pain, they're going to be on aspirin, they're going to be on NSAIDs, and they're going to abuse these medications day and night. So they could develop iron deficiency anemia due to GI blood loss. Okay. They could have iron deposition in their macrophages in the reticular endothelial system, in the joints as well. They could have leukocytosis and neutrophilia during flare-ups. Okay, so these are very, very common, and a question that would come from here. I think they're probably going to put it in an anemia of chronic disease, or probably they're going to tell you that they're taking these sort of medications. What do you expect? Iron deficiency anemia, inshallah. Okay. Next up, connective tissue disorders. Now, from the term connective tissue disorders, you need to keep in mind that they're going to have bleeding, they're going to have bruises, right? And why is this so? This is because of the increased fragility of their capillaries and their connective tissue, which would lead them to be more, perceptive to incidents like bruising and bleeding. طيب, you need to keep in mind that this has absolutely nothing to do with their platelet aggregation and clotting factors. So it's going to be normal. Sometimes they could be affected. These are very specific conditions like Marfan and Ehlers-Danlos, but typically they're normal, okay? So it's the only takeaway from connective tissues. Now, let's look at infectious diseases, right? This is what the entire block is really all about. So what are these sort of red blood cell disturbances that we could encounter? First of all, anemia of chronic disease. It's common and seen in all infections, no exclusions, right? Again, hepcidin mechanism, your hemoglobin is going to drop within the first week of the acute inflammation. Then when you're in resolution, it's going to peak shui, and then it's going to fall back down, all right? So this is something that you need to keep in mind. Something else that you could have transient marrow aplasia or selective erythroid aplasia in some viral diseases, okay? Or it could be bacterial. Now, something صراحة that I've seen a lot in USMLE and a lot in questions is patients who have uh, sickle cell disease are very prone to being infected by parvovirus B19. And they will develop something we call a plastic crisis, where basically they have this chronic hemolytic anemia that they reach, a plastic crisis. It's like they're out of red blood cells dramatically. Okay. Then we have, you can see hemolytic anemia in all of these infections. Okay. Bacterial, viral, whatever it is, you will see it. You will see hemolytic anemia. Okay. And immune hemolytic anemia due to cold antibodies. All right. And focus on the word cold antibodies. You see it in Listeria and Mycoplasma. Okay. Now, for white blood cells, it's a bit long. You need to keep in mind that you could have an entire mosaic of findings when it comes to white blood cells, and it really depends on, how acute, how chronic the disease is. However, keep in mind that if it was a bacterial infection, 99% of the times you're going to see neutrophilia. Okay, so if you see neutrophilia, just keep in mind that usually they're trying to tell you that it is a bacterial infection. Leukopenia, you'll see it usually in all diseases, all right? But most likely it's going to be seen in viral infections. Okay, hepatitis, infectious mononucleosis, rubella, measles, shigellosis, pneumococci, meningococci, staphylococci, all of these would cause leukopenia. All right, now there are some morphological changes that you guys need to keep in mind when it comes to neutrophils in bacterial infections. First of all, this is what we call the Abdullah bodies. So it's basically this blue, coloration here on the side, right here. Okay, this is what we call Dole bodies. All right. Now, then we have toxic granulation. So if you can look at these neutrophils, right, and you can see there's just a lot of activity. There's a lot of people in the party, in the cytoplasm, right? Basically, this is toxic granulation. Why it happens? This happens in severe bacterial infection, okay? And this indicates that the bone marrow is rapidly turning out and activating neutrophils to go and fight off this active stimulus that's attacking the body, okay? Here, you can see that within the cytoplasm, we're having these basically clear, round, fluid-filled cysts. These are what we call vacuoles, okay? And they're just scattered throughout the entire neutrophil, eating up this active pathogen. And this is what we call toxic vacuolation, okay? Now, this is pseudo-Pelger-Wheat anomaly. See, this could be congenital. But first of all, let me tell you what's the anomaly here. It's basically we have hyposegmentation. Usually it's 3 to 4 segments. The nucleus is divided to 3 to 4 lobes. Here it is only 2 lobes, as you can see. This is a very important marker for myelodysplastic syndromes, or even could be due to certain drugs that have been taken that will induce it, like valproate, or severe infections. Or this could be just congenital. Okay, but see, I just put it here because it's in your slides and you have to recognize it. Now, if the patient is having lymphocytosis, what do I need to think about? I need to think about viral infections. Okay, I need to think about infectious mononucleosis, cat scratch disease, CMV, rubella, mumps, hepatitis, this entire family. If the patient has lymphopenia, then this is very common in measles. If the patient has eosinophilia, you see eosinophilia in parasitic and fungal infections. If the patient has monocytosis, very common in tuberculosis, syphilis, and subacute bacterial endocarditis. Monocytosis is not common in just viral or any random bacterial diseases, but it is seen in tuberculosis and syphilis. Very high yield, very important. Basophilia is extremely rare, but if you see it, think of TB. TB, influenza, hookworm infestation, usually TB. Okay, infectious mononucleosis, or what they call it, the kissing disease. It's from EBV virus via saliva transfer It activates your CD8 T cell response, and the patient is going to present with you with fever, generalized lymphadenopathy. They're going to have sore throat as well, and they can also have hepatitis. Usually the question is going to be like this gentleman, probably like 27 years old. He has fever, generalized lymphadenopathy, and sore throat. خلاص, this is infectious mononucleosis. They might mention that he's been active with certain partners. If not, they could tell you that this patient is an infectious mononucleosis diagnosis. What are you expected to see on his smear or in his bone marrow, for example? You have to say that you'll see atypical lymphocytes. Look at this lymphocyte. It looks like it's been like hanging from a cliffhanger, right? By all of these red blood cells. This is an atypical lymphocyte, right? And you're also expected to see lymphocytosis on their lab results. So this is things that they might ask you. Okay, so it's either this or that. Like, now, clotting abnormalities and thrombocytopenia in infections. So this first three right here is clotting abnormalities. If the patient is having DIC, and if it was gram-negative septicemia, gram-negative organisms are going to be meningococcus, E. coli, Proteus, Pseudomonas. Just be familiar with the names. Then you have the gram-positive again. Just be familiar with the gram-positive ones. It could also be viral, and viral could be due to hepatitis, measles, rubella, infectious mononucleosis. So there's a pattern that you need to follow with what kind of abnormality these organisms carry. Now, if the patient has infectious mononucleosis, CMV, rubella, and actually I'm going to emphasize infectious mononucleosis because it's been repeated a lot, the patient is going to have thrombocytopenia. And you will see thrombocytosis usually and only during active phases of the infection. So if the infection is in acute stage, you'll see thrombocytosis. And I think it's self-explanatory because we're trying to fight off this active pathogen that just happened to step inside our bodies, right? Okay, now let's talk about the bone marrow abnormalities. But first, we need to talk about the organisms. So if you identify an organism within the marrow macrophages, it's most likely it's going to be TB, Salmonella typhi, Candida, histoplasmosis. If you have granulomas within your marrow, this will push you to think that the patient could be having disseminated TB or histoplasmosis, okay? And if you happen to have a culture from marrow aspirate, all right, and if something is growing on a marrow aspirate, it could be histoplasmosis, TB, brucellosis, salmonella. I genuinely feel that you guys need to just pick up histoplasmosis and TB because it's common through all three different scenarios, right? And yeah, now infiltrates. So many things could infiltrate our bone marrow, but not everything that infiltrates happen to be malignancy. It could be non-neoplastic, could be a storage disease. You know, do you remember these boring storage diseases back at first year? Gaucher, Nyman, they will still haunt you in fourth and fifth year. However, they do infiltrate your bone marrow, okay? So this is the non-neoplastic side of it. The neoplastic side of it could be leukemia, which is the primary part, you know, affects your bone marrow, of course. Secondary to that could be neuroblastoma, non-Hodgkin lymphoma, Wilms tumor, retinoblastoma as well. All right. So I think it's best that you just be familiar with the names so that if a question comes and attack you, you'll be able to know that from which category this is coming from. Okay. Now, hematological problems that happen to be in heart diseases. First of all, hemolysis from mechanical injuries. All right. What do we mean by mechanical injury? Anything that is like prosthetic heart valves, a patient who has their VSD and PDA, patent ductus arteriosus repaired. You know, these are all like mechanical injuries that could arise. So you could have hemolysis from it. Okay. So this will lead to, you know, you're going to have hemoglobinemia, right? Because you're breaking down the red blood cells, the hemoglobins are going to be out. You can have hemoglobin in your urine, or you can even have IDA, right? Iron deficiency anemia. Now, in patients who have cyanotic congenital heart diseases, right, they'll have low oxygen in their bloodstream. And this is going to push the kidney to release EPO, erythropoietin. And this is going to make the bone marrow be more responsive and produce more red blood cells. This could lead to a condition called polycythemia, where you have like really, really viscous blood, you know? And here, in such scenarios, you're gonna have higher iron requirement, okay? And you might see some sort of mild macrocytosis. Now, in heart diseases, especially the congenital ones, you could happen to see some bleeding tendencies. All right. Why? Because the patient could be having low platelets, so they can have thrombocytopenia, or they could have low fibrinogen, or they could be basically having a defective ability in retracting the clot, so the clot is not able to stabilize well. They could be having low prothrombin. They could have low factors of 5 and 8, which will basically reduce the ability to clot, right? And throughout all of this, you can see that there's something that we call fibrin degradation products. And basically, this is the evidence that clots are being broken down in your blood and being formed. Okay. Now, anemia and renal disease, usually it's because when you have a renal disease, you'll have, let's say, for example, you'll get to have like some sort of deficiency in the production of erythropoietin. So that will be dysregulated, right? Could be seen in dialysis, in infection, secondary hyperparathyroidism, could all happen. So now what will happen is that you're going to have normocytic normochromic anemia, all right? So it's very similar to the anemia of chronic disease, okay? However, you need to understand that the survival of these red blood cells are going to be shortened. Why? Because now they're going to be more mechanically fragile. So any bumps, any kind of stress they're going to be put under, they're just going to die. They can have autohemolysis, decreased deformability, and they can even have some sort of metabolic defects. So just the takeaway is that if you're having anemia due to a renal disease, you just need to pick it up that it's deficiency in EPO production. Okay. Now, in renal diseases, you have this thing that we call a Burr cell. A Burr cell, it's very important that you know where it is seen. It's seen in uremia, it's seen in hemolytic uremic syndrome, and some other specific renal syndromes. But the most important one is the hemolytic uremic syndrome. Okay, this is how they look. Then you have fragments, RBC fragments. You see this where? You see this in malignant hypertension, right? You see this in hemolytic uremic syndrome, and you see this in renal cortical necrosis. And you also see it in thrombocytic thrombocytopenia. You can even see it in SLE. Okay. Then you have the megaloblastic changes. So this is basically, due to vitamin B12 or folate deficiency, where you can have megaloblastic anemia. All right. In the context of renal disease, you will have folate deficiency in chronic renal disease due to hemodialysis, due to immunosuppressive drugs, or due to poor dietary intake. Okay, because patients who are on hemodialysis or who have some sort of chronic renal diseases that are going in the long run, they become cachectic, their intake becomes really poor, so they are more prone on having folate deficiency, which will lead to megaloblastic anemia. Okay. Now, here you can see that we have tons of red blood cells compared to, let's say, a neutrophil, for example. All right. Relatively, it's just a lot. And this is what I mean by polycythemia. All right. So if we had something that is causing, right, excessive production of erythropoietin, and this will only make me think of renal tumor cells, right? Or renal ischemia, because ischemia and low oxygen is going to cause it to have higher EPO, or even a hydronephrosis. It's going to push it to produce more red blood cells in the bone marrow. Okay. And this is basically just a granulocytopenia. This is usually seen during hemodialysis, okay, where basically you have granulocyte sequestrations in the pulmonary vascular bed. And lastly, neutropenia. Neutropenia also happens, okay? And it's also seen, when you also have folate deficiency in renal failure. Okay, neutropenia is basically low levels of neutrophils in the blood. Now, You will also happen to have some coagulation dysfunction in renal diseases. So if the patient is uremic, okay, they will have less factors of 5, 7, 11, and 10. All right. This will cause what? This will cause vitamin, usually seen due to hepatic dysfunction or seen due to vitamin K deficiency. Okay. Like, what are the factors that need vitamin K? So it's factor 1, 9, 7, and 2. Sorry, 1, 10, 9, 7, and 2. Okay. So, yeah. So here, 9 and 10 are needed, right? And 7 also. All of them, they need vitamin K. So if the patient is uremic, usually they're vitamin K deficient. They're going to have less of these coagulation factors, which will lead to coagulation dysfunction. Then you have nephrotic people. People who have nephrotic syndrome are going to have more fibrinogen, more factor 8, all right, and more factor 7, 10 complexes. So they're gonna become hypercoagulable, right? So they're more prone to have, thrombosis. They're more prone to have, the ICs as well. So this is something to keep in mind. Platelet dysfunction in renal disease, usually they have mild thrombocytopenia with a bit of platelet dysfunction, okay, which will, of course, cause bleeding. So we are done with the hematological manifestations of systemic disease. I know I've speed run a bit, but I'm trying to make sure that we don't spend. I'm trying to make sure that I make it as precise as possible. So this is a question for you guys. It's a 34-year-old woman with a history of 6 years of rheumatoid arthritis, presenting with fatigue. Her hemoglobin is 9.8 with an MCV of 84. She happens to have her platelets and WBC at normal levels. Her iron studies showed that she has low serum iron, low transferrin. Her transferrin saturation is 12%. Her ferritin is 340. That's really high. And the peripheral smear is normocytic. What is your most likely diagnosis? So, diagnosis would be anemia of chronic disease, right? Because this patient is, her profile, her iron profile fits the profile of anemia of chronic disease. And as we mentioned previously, rheumatoid arthritis is a chronic condition of this continuous inflammation happening to the joints, right? So you will see anemia of chronic disease. So what mediated, that the iron happens to be trapped in the macrophages and basically reducing intestinal iron absorption in the rheumatoid arthritis patient? That would be hepcidin. So this is a 22-year-old woman with a mallow rash, arthralgia, positive ANA and anti-DSN-DNA antibodies. Which of the following is the most common immune-mediated hematological manifestation of her disease? So we mentioned, can you pick up that this is SLE? We can. So which of the following would you see in SLE? That would be thrombocytopenia. Okay. The warm autoimmune hemolytic anemia from the lecture, okay, only from the lecture, it was listeria and monocytogenes. Okay. Like a 60-year-old man with fever, productive cough, lower consolidation, has a WBC of 19,000 with a left shift. Peripheral smear shows neutrophils containing coarse, dark cytoplasmic granules, peripheral pale blue cytoplasmic inclusions, and cytoplasmic vacuoles. These findings are most consistent with which of the following? So it's going to be reactive neutrophil changes of bacterial infection. This is basically describing toxic granulation, Dola bodies, and the toxic vacuolation that we've discussed earlier. So that's it for our third lecture. Now we are moving to the easy parts, inshallah. AI, robotics, advanced endoscopy. I genuinely have no clue why you guys are taking this, but let's roll. So AI. AI is moving in a scary direction, but it has a great clinical impact. Okay. Personally, someone who's been very active in clinical work and research, AI has been tremendously helping and pushing clinical work. So how? That's the question, right? How is it helping clinical work? First of all, it can help in diagnosing. طيب. But actually, before I go on how, let me discuss the types of AI so that guys can able to understand what I'm trying to say. First of all, my personal favorite and something that I've worked with personally is machine learning. Machine learning is basically an AI tool. It's basically like a software where you feed it data and you teach it how to analyze data, right? So it can be able to diagnose, it can be able to predict, it can be able to tell you that, okay, if this patient has this demographics, if this patient has this profile, right, he'll be at higher risk of having, ABC, for example, okay? Or it can even predict the outcomes of this patient if they happen to be in surgery, or if this patient was discharged from the hospital, right? It can be able to predict, you know will this patient be readmitted or not. Okay, so one of the things that can help us is machine learning. طيب. Deep learning is something that is able to analyze and break down these complex images and texts. All right. Computer vision is, things that have, people in radiology and pathology, happen to use. They find it easy in like diagnosing and picking up things that they were maybe like due to human error or human fatigue, they're not able to see. Okay. So now we come up to how it really helps. It helps in diagnosing, helps in predicting, and we've published a lot of papers on predicting. It also helps in decision support. Okay, even like us now these days, when we go use ChatGPT, Claude, whatever, sometimes we use it, in helping us in supporting our decision or explaining if our decision is right or wrong from their perspective. Okay, it helps in documentations, in writing notes, in making summaries, in writing discharge letters, and of course, education. Okay, so this is where really AI helps. So this is a beautiful figure done by AI itself. Okay, so here we're talking about an input. An AI model will not be useful without us humans. Okay, because we collect the data, right? We collect the raw data, all the images, all the vitals, all the profiles, all the labs. We collect it, we give it to we feed it to the AI model, and then it helps us, in detecting, in predicting, and in, making summaries or like, analyzing triages, right? However, we cannot purely depend on this without a doctor's review. Okay. And for a doctor to be able to review and question this AI model, the AI model must be understandable enough to be challenged. Okay, does it click? Like an AI tool, of course, it must be clinically useful, externally validated, all right, means by us humans, fitted into the workflow, and monitored after deployment. طيب. However, we need to watch for some bias. Why? Because sometimes it can be, biased towards sort of finding or not. It could have some sort of automation bias, which, for example, it does, oh, خلاص, that's AI. AI told you, like, for example, you guys probably yourself with questions right now, and then be like, you go up, paste a question to ChatGPT, and be like, well, answer B makes sense, but AI said it's A. خلاص, I'll go with A. That's automation bias. It's like, خلاص, I'm just being blind. Whatever AI says, I follow. All right. Sometimes AI will hallucinate. And those of you who it's the task that it was asked for. Sometimes privacy and security, just a moment. Privacy and security, sometimes the data that we're feeding, right, is a very sensitive data. We're feeding it information about patients that's confidential. So sometimes it could leak this data, right? So this is something. Then the model drift. Sometimes we're operating on a model, خلاص, we're using this model for 3 to 5 years. It could get outdated, right? And their performance could decay with time. which would require system updates, yep, yep, yep. Okay. And sometimes we can have some sort of liability, you know. So this AI thing is whose responsibility, the info it gives us, so there's some sort of unclear responsibility, right? This gray shade, gray zone. So these are the things that you probably want to watch for. How is this going to come in the exam? They're probably going to give you a scenario and they're going to tell you, for example, try to pick up what risk is AI, you know, putting these patients at. So is it automation, hallucination, privacy, model drift, liability? So if you understand these, probably inshallah is going to be easy. Now, robotics. Robotics, honestly, ever since the introduction of robotic surgery into the world of surgery, it has transformed, outcomes of surgery. It has transformed the patient experience overall, right? Before they used to cut the patient open, uh, into four and try to just fix a simple tiny operation. Now they go in, right, with the robotic arms, minimally invasive, do their laparoscopies, fix and stitch all, and just within like 6 holes or even less. That's magnificent. So just for the sake of completion, I want to just show you here. This is a surgeon console. So this is basically his 3D view, his hand and foot control to be able to control the robotic arms. And this is the patient cart. So this is the patient, and these are the robotic arms right here, right? With all the instruments that he needs. And of course, the team around, right? This is how basically they do their surgeries. Now, these robotic surgeries, they do improve the surgeon's ability, right? In their ability to go in minimally invasive and, fix up the patient, whatever pathology they're suffering from. However, the outcomes of that surgery is purely dependent on the surgeon. If the surgeon is incompetent, then his outcomes are going to be horrible. So it's not the robot. You know what I'm saying? Uh, so this is something that you guys need to understand. Probably going to tell you which of the following is true, which of the following is false. If this statement pops up, you need to be able to understand robots only improve the surgeon's performance in the surgery. That's it. Of course, it affects the outcomes from a way that less infections, less length of stay in the hospital, because it's minimally invasive. But still, outcomes of the surgery itself is purely dependent on the surgeon. Now, where do we use robotics these days? We use it in urology, like when we're doing prostatectomy. We use it in gynecology when we're doing hysterectomy. We use it when we're having, hernial fixation and lobectomy. I've seen one. It's so cool. They use it in transoral robotic surgeries. They can even use it in selected pancreatic or like liver diseases as well. So it's really cool. It's really magnificent, honestly. Now, the benefits are that you're going to have a 3D magnified view. You'll be able to see everything. You're going to have better dexterity. You know, even if the doctor happens to have any sort of tremors, that's going to be filtered out. Smaller incisions, as I mentioned, right? Less complications post-op. However, the limitations that you're going to face, it's very expensive. These machines are really expensive. And now for you to be able to use it, you need to be highly trained. You need to be able to use it properly, you know what I'm saying? And, it needs a lot of backup in case things happen, things go wrong. So in my opinion, these are just more of like logistical limitations and not something that would uh, clearly impact the patient. Yeah. It's basically the surgeon and the robotic itself, and the robotic arms and stuff, right? Now, advanced endoscopy. When you see the term advanced endoscopy, you're basically talking about a surgery through a natural orifice, a natural opening in the body. So the perfect example is, the GI tract. Like, for example, if they go through the nose to fix something wrong in your biliary tree, for example, this is what we call advanced endoscopy. Okay. You get to see things in HD imaging, you get to sample, you get to collect a biopsy, you get to resect, you get to drain, you get to reconstruct, you get to suture, all through a natural orifice. And that's an advanced endoscopy. It's honestly so cool. Now, AI can help in detecting polyps, right? And like a very famous disease, familial adenomatosis, adenomatous polyps, right? The FAP one. AI can help in detecting these polyps, can help in detecting them, even helps in detecting adenoma detection, right? But that doesn't really translate to fewer cancers or lower mortality or less harm. Detection does not mean that, we go and treat. صح? It's only just to say that this is the prevalence, right? This is the percentage, the chances of having polyps in such population and whatso, right? So the quality again goes back to the surgeon and the team. Like for example, prepping the bowel, all right, making sure that it's a clear field so they can be able to visualize, right? The cecal intubation, trying to reach the entire colon. The withdrawal time, when they're withdrawing their instruments, they're carefully looking around for any polyps, right? And the complete resection, the removal of the entire polyps. This all again depends on the surgeon and their team. Okay. Now, so we have different kind of endoscopies that we do, and this really all depends on the lengths that they do. So we have basically endoscopic mucosal, right? We have endoscopic submucosal, we have endoscopic full thickness resection, okay? So endoscopic mucosal, or just goes just a bit, to the superficial submucosa, as you can see here. طيب, again, this one goes all the way to the, through the entire submucosa, and this one covers the entire thickness of the lumen, all right? Now, endoscopic cure, again, can depend on the level of invasion. So this is number one. Depends on the margins, okay? Depends on the lymphovascular invasion of the tumor or whatever we're resecting, let's say polyps in this scenario, all right? And of course, it also depends on the team, right? On the plan that they get prepare in their multidisciplinary meetings, right? To treat these patients. Okay, so it's multifactorial. It's not just AI. It's not just these robotics that they're using. Now, something else is what we call the third space endoscopy, where you work, in the submucosa. So here you basically enter the mucosa, all right, and then make a tunnel within your submucosa, and you can basically treat whatever you want through the submucosa. Okay, like for example, here you have achalasia. You can treat that through the submucosal tunnel. You can do your Zenker diverticulum. You can do your refractory gastroparesis. So this is just an idea, right? This is where you go and treat, and then you basically close it. There's no any external incisions. All good, right? Now, ERCP and EUS, these could be therapeutic and not just diagnostic. I just don't put them through just to diagnose. I can put them through, I'll pick up a diagnosis, and I can even treat. So the ERCP, for example, right, you can let it go through the stomach, right, all the way to the duodenum here. And here, this is your pancreas, right? Here you can go in and, free this pancreatic obstruction, right? It helps with stones. It helps with, picking up the stones, helps with, freeing up strictures, right? EUS also helps similarly, okay? You could also get you some tissue sampling, like, you can get some FNAs. You can drain biliary trees, after failed ERCPs. It could help in removing gallbladders, you know, fluid buildup like drainage. You know what I'm saying? If they have any sort of pseudocysts, especially in the pancreas, pancreatic pseudocyst necrosis, you could go in and drain it as well using an EUS. So basically, these are their uses. Takeaway, they're therapeutic and diagnostic. Okay. Now, metabolic therapy and endoscopic rescue, you can use, these robotics for metabolic purposes, like bariatric purposes, like endoscopic sleeve gastroplasty, all right, like treatment of leaks, strictures, and fistulas, intergastric balloon, you know what I'm saying? So they all can be used to treat these metabolic surgeries. Endoscopic rescue, all right, now, what you basically can do if there's any sort of bleeding that's happening, intra-abdominally, for example, you can endoscopically go in and clip it. All right. If you have a perforation, you can put some clips. You can suture it. If there's any leaks or any fistulas, you can lock it up. You can suture it as well. You can put stents in there. If there's any collection, any pus, any that, you can go in and drain. If there's any sort of obstruction, you can open it up and put a stent, right? So this is all things that we call as endoscopic rescue. It goes in and saves the day. Okay. However, the success depends, of course, on early recognition, and having a team that will back you up. Okay. And that's really it for AI and robotics in medicine. Now we move on to our final lecture for this session, which is called the palliative care. Now, I know it's a bit wordy, but I'm just putting all the important things in one slide for you here that you can pick up. Palliative care is not just end of life care, it's a interdisciplinary approach of a group of doctors, nurses, spiritual providers, right, that happen to give care for the patient, okay, throughout their entire disease. Okay, so usually people go for palliative care خلاص when all active treatments fail, and that's wrong. This is what basically the structure is trying to tell you, that we're trying to make sure that it happens all the way from the beginning. Okay, should be started early and not just at the end, and it should be need-based, not prognosis-based. Not, yani, of course, it's prognosis based, but not just that. It should also be need based. Some people actually really need it. People who are facing like serious illness, life-threatening illness, and it's impacted them and their entire family. Because in palliative care, the unit that you're treating the person and the family, right? So it should be need based. All right. It's a multi-dimensional approach. So that's something you also need to keep in mind. Sometimes, however, death rates still remain to be at 100%. All right. But now, what we're trying to achieve is not to fix the mortality rate. We're trying to make sure that people get to live longer with these chronic multi-morbidity factors that they're going through. Okay. And you can cure sometimes, treat often, but you need to always try to provide comfort for these patients. Okay. So palliative medicine and palliative care are not the same thing. Palliative medicine is a specialty where they focus on managing symptoms and pain and caring for the patient. Palliative care, as I mentioned, it's an interdisciplinary care involving a group of people from doctors, pharmacists, social workers, psychologists, spiritual providers, all of them to make sure that the patient is comfortable. Like, definition of who is to, palliative care is an approach that will prevent and relieve suffering. And it needs to improve the quality of life for adults, children, and families. How? By 3 steps. Of course, we need to early identify that these patients are having some sort of life-threatening illness. Then we start palliative care. Then we do an impeccable assessment, assessing everything that they have, and then coming up with a rigorous treatment plan for their pain and whatever things are making them feel uncomfortable. Okay. Now you might be like, okay, so is the source of suffering only pain? No. It could be psychological, it could be spiritual, it could be emotional. This is why we have a team that is interdisciplinary team that provides care for these patients, so they can prevent and relieve all the sources of suffering if possible. Now, as I mentioned, it could be psychological. They can have this fear and anxiety, right? They can have physical pain. They could have family issues, financial issues. They could have nobody, no friend, no spouse, no family. They could have some fear of death, guilt, so many things that they could possibly be going through. And this is what really coins the idea of total pain, which was made up by Cicely Saunders. Okay. Now, so the quality of life is very important, right? And Sir Kalman back in 1984 came up with this thing that we call the Kalman gap. So what is a Kalman gap? It's basically the individual's hopes and expectation minus their current reality and experience. Okay, so the narrower the gap, the better is their quality of life, because whatever reality they're living in, it's matching whatever they're expecting. Okay, and the opposite is true. So it's an inversely proportionate relationship. If whatever they're expecting is way far from their reality, that's going to be a wider gap, right? So you're going to have lower quality of life, less healing, more suffering. Okay. Why is this important? It's important so that you can actually perceive what the patient is going through and improve their reality. And by improving their reality, you can also try to decrease the pain, make them more comfortable, see what they actually need and fix that. You can modify the expectations. See, something about palliative care, and this is, I think, a misconception that, usually people who have, like, let's say, they find out that they have an incurable disease. We try to give them hope. We try to tell them that things are going to be better, but that's not really you meeting their expectations that they want to hear from you, right? Honest transparency with your patients are going to put them more at relief, and is going to get that gap narrower if you be purely honest with what is actually going on with them. All right, you need to tell them that, okay, you have an incurable disease, and this is how it looks for you over the next X period of months or years or days even. Okay, so this is how you modify their expectations. Okay. Now, the Bradshaw taxonomy of social needs. So we have 4 aspects that you need to cover. First of all, what people want, and that's called the felt need. All right, and that need turned to become an action. So it's an expressed need. And then some needs are defined by professionals or experts. This patient, for example, needs, ABC. So that's a normative need. And different services levels between similar populations, that's called a comparative need. Okay. Very possible MCQ. Now, the Maslow concept in palliative care, first of all, you need to understand that palliative care needs to cover and address all layers of human needs, not just their physical symptoms. So they need to cover their physiological needs, like food, rest, providing analgesia, rehab, safety. They need to feel protected from, losing control, because they have no control over whatever is going on with them, right? They could have some sort of fear of death. So this is also something that palliative care people need to, touch base on as well. Love and belonging. They need to be caring, affectionate, having the caregiver role, allowing them to heal mentally, spiritually, and physically, right? And then esteem, recognizing the achievements, that they've made it this far, right? And try to make them stay adherent to the protocol, the treatment protocols that they're trying to get, right? And then self-actualization, where you involve them in, like, advanced care planning. You show them how it's going to happen. You tell them, you be fully transparent with them, and make them involved in decisions, right? Them, and of course their family. All right. So the Maslow is just trying to tell you that palliative care should touch upon all of these layers. All right, because all of these will make up the human need. Then here we have the evolution of palliative care. So it started with Cicely Saunders, where she was the founder of modern hospice movement, right? Introducing the total pain. Then Balfour Mount came in and started using the term palliative care. And then back in the 2000s, right, palliative care became a right to life, right? So now everyone has the right to have access to palliative care. And then in 2014, It was strengthened, okay, as part of comprehensive care throughout life. So it's not just towards the end of life, it should be throughout the life. Okay, ever since they pick up this life-threatening illness, palliative care should start. Now, prognosis, right? So people with cancer usually they have high functionality, and then they start to have this short, steep decline that will bring them to death. This is how it looks for them. People with organ failure have ups and downs, ups and downs. You see these dips right here with partial recovery in between. Okay. People who have, frailty and dementia, they have a really low baseline and slow, steady decline to death, unfortunately. Why this matters? This matters because it makes us become more realistic in making our treatment plans, uh, trying to identify what are our goals here to make sure that the patient is cared for properly, and modify their expectations. So we go back to Calvin Gap again. Okay. Now, how do we deliver palliative care? We have three modules. We have first the dichotomous one, where here, whatever life-prolonging care is being given to the patient and palliative care, they're two separate things, right? They're dichotomous, two separate things being given to. Okay. Integrated is where you have palliative care being involved early on, and you're giving disease-directed care, like medications, right? Maybe chemotherapy as well, and at the same time, palliative care. Okay. Throughout the entire time of disease progression. The bow tie delivery is where the treatment and the palliative care both overlap. And when they cross over, you're basically more involved in symptom management. Okay. And the care here is going to shift according to the patient's need. Okay. So modern palliative care is more towards integrated, early, not delayed until active treatment stops. And the layers of palliative care. So we have three. The first layer is, your palliative care within the first 12 months before death. And then the palliative end of life care, it becomes 6 months or less. And then the final days, it could be hour to days. This is the comfort care. This is where, khalas, all that matters is the patient to die comfortably, and this is maybe sometimes one of the biggest wishes of people, of the family of patients, that if, for example, they're not there and the patient, let's say, died, the first concern, the first thing they ask, did he die in pain? Did he die comfortably? So this is something that, matters. Now, is palliative care comfort care? No, it's not the whole thing. However, it is part of it. Palliative care is part of, comfort care is part of palliative care. Okay. And it's the final layer of palliative care, not just the entire thing. Okay. So in Saudi Arabia now, alhamdulillah, back in 1990, KFSH have, kick-started its integrated palliative care, which was the first in the Arab world. And now we have, more advocacy and patient right promotion in public, and people now understand that they have rights to palliative care. And ever since 1990 till now, we have more structured policies and healthcare integrations. And now you can see palliative care has been integrated across multiple disciplines in the hospital, and now there are official professional training programs that train teams and train doctors on palliative care. Okay. So for people who decide to not be in the hospital anymore and just want to spend their last days at home, okay, it would be safe that I consider home administration, if it would be safe that, these people go to home if we provide them with the appropriate things to keep these patients comfortable. So we give them opioids, we give them benzos, we give them antipsychotics, and any other symptom that the patient is suffering from, and we can relieve it by giving them medications for it. Okay. However, we need Monitoring protocols. It's not just خلاص we tell them خلاص take these medications or put the patient at home. Sometimes families are not ready, so we need to assess readiness. Okay, we need to monitor continuously. We need to make sure that the patient is safe, the patient is at appropriate comfort levels, you know, and there is some sort of clinical stability at home. طيب. Now, when we need to start discussing the call of care discussion, it should be a balanced discussion where the patient is our center of our focus, okay? And we need to make sure that the patient understands their illness. We need to make sure that the patient is aware of their prognosis. We need to respect and take in their wishes, their goals, values, and hopes, no matter what they are. Even if they don't make sense to you, doesn't matter. Makes sense to them, خلاص, we roll with that. Medical representative, we should have someone who's a spokesperson as well on behalf of the patient. And we should be ready for any code status. And we, of course, we at the end, we ask them where did they prefer to be? Do they prefer to be at home? Do they prefer to be in hospital? Two things you want to avoid when you're discussing such goals with the patient. First of all, medical nihilism. Sometimes people would withhold treatments just because خلاص يعني the illness itself is life limiting. At one point the patient is going to die. Why do I bother? Right? This is absolutely wrong, and you're just going to the extremes. This is something that you should avoid. Second thing they should avoid is medical heroism. You're not a hero by providing every possible treatment, and you just ignore that this patient is actually in his end of life, right? There's no point putting the patient in pain and like uh, extra finances, right? So, خلاص, if the patient is in his end of life, your main goal should be his comfort, his safety, his dignity. Okay? So not every possible treatment, خلاص, every possible treatment in the medical textbook I need to give him. So this is medical heroism, and we try to avoid it. Okay? Communication basics. First impression is, of course, within the 10 seconds. You always have to be smiling. You also always have to have this welcoming attitude, right? And having a proper introduction really matters. Okay? There's three ways you communicate with the patient. Verbally, by delivering the prognosis, illness awareness, coping mechanisms, but there's also the paraverbal way, the way you speak, the way you deliver, the way you're pacing your words at matters so much. If you were aggressive, the patient is gonna feel anxious. If you were welcoming and soft and like providing them warmth, they're gonna hear you with open arms. Okay, nonverbal is the way you stand, the way you're gesturing at them, your facial expressions, the distance you are. So usually you get closer to the patient. You'd sit at their level. You'd make sure that your facial expressions are neutral. You know what I'm saying? Try to make sure that you're not, angry or look frustrated, because will only push the patient away from you in the room. All right, assalamu alaikum, everyone. I hope everyone is doing great. Welcome to part 2 and the final part of the crash course to MID. Today we'll be covering 3 lectures, inshallah. The renal manifestations in systemic diseases, geriatric medicine, and shock and sepsis. All right. Okay, so this lecture is very similar to the hematology one that we had earlier, but this is more fun because you actually understand what's going on. So, we will start with diabetic nephropathy. This is an extremely high yield topic, very oftenly tested in boards, exams. So you'll see it a lot. You're going to see it in 4th and 5th year as well. So, just in a nutshell, someone who has chronic diabetes for too long is with time, he's going to produce things that we call H, or advanced glycogen end product. This is going to actually damage our retina, our neurons, and eventually the kidneys. Now, of course, today we're gonna put more focus on the kidneys. So what happens is that these aged products are gonna deposit in the GBM, all right, so in the basement membrane of the kidney, causing it to thicken. Okay, keep that in mind. So this is number one. So in light microscopy, in a diabetic nephropathic patient, you're expected to see GBM thickening. Second thing that age is going to do is that it's going to cause vasodilation, and it's going to affect the afferent arteriole more than the efferent arteriole. So imagine the blood that's going inside the kidney being, enlarged, like vasodilated. So what's going to happen? A lot of blood is going to rush in, and then it's going to cause interglomerular hypertension and hyperfiltration. So when this hyperfiltration happens, a patient is going to come to you presenting with albumin in his urine. Of course, the patient's not going to come and tell you that there's albumin in his urine, but when you do urine analysis, you're going to see that there's albumin in their urine. And then this can, with time, after this high intensity, blood being pumped into the kidney with hyperfiltration, with time, the patient may suffer from advanced tubular hypertrophy. So this is what really happens in a nutshell. Now, my question to you, and I'm going to keep you with it, at what stage does the patient come and present with albumin in his urine? So this is the answer. For us, whenever we're dealing with any disease in the kidney, all right, we love to stage it. Makes it easy for us, right? Now, of course, this might look overwhelming, but I'm going to break it down to you. The very first thing that happens in stage one, the kidney is functioning normally. We have hyperfiltration, yes. Of course, that's the damage part, but the GFR is going normal. Everything's fine. In stage number two, which is the silent phase, this is like the killer. This is where you break it or make it, right? What's going to happen here is that you're going to have GBM thickening, you're going to have hyperfiltration, and albuminuria is going to start, is not going to start here. It's going to be normal. The GFR is going to drop. It's going to start in the third phase. In the third stage, this is where you'll start to have microalbuminuria, like between 3 to 300. And stage four is where you're going to have macroalbuminuria, where you're going to have more than 300 milligrams per day. And stage five, that's going to be your end-stage renal disease. Of course, as the stages progress, the GFR is going to drop. Now, what you might be asked about the GFR, of course. That's number one. So you need to learn these ranges, I believe. Second thing, when does albuminuria start? That's very important. Okay. And probably you guys might get a question about stage two. All right. You just need to remember that there's no albuminuria in stage one and two. Okay. Just keep that in mind. So I hope this is clear. Now, in diabetic people, in diabetic nephropathy specifically, we have one thing that if you see in a light microscopy, khalas, this is pathognomic for it, which is the Kimmel-Steele-Wilson nodules. So these nodules that you see, these are called Kimmel-Steele-Wilson nodules, okay? You also have mesangial expansion, you will have the GBM thickening, and with time, right, with time, you're gonna have this thing that we call eosinophilic nodular glomerulosclerosis, okay? So they might get you this in your question, or they might tell you in the MCQ, Kimmel-Steele-Wilson nodules, or the opposite, where they tell you that a patient who presented, he's known case of diabetes for like 10 years, and they tell you that, there's albumin in his urine. So khalas, you're gonna think he has diabetic nephropathy. They'll tell you, what are you gonna expect to see on his light microscopy? And this slide is your answer, okay? Like, how do we manage these cases? Now, first of all, we need to think about, before managing, we need to think about how can we prevent or catch it before it progresses further, right? So if a patient who's a type 1 diabetic patient comes to you, khalas, let's say he was diagnosed today with type 1 diabetes. 5 years later, you're gonna start screening him for diabetic nephropathy, diabetic retinopathy, diabetic neuropathy. You screen them for all diabetes complications. Now, a very important thing, is that usually, and most of the times, patients who have type 1 diabetes and proteinuria present with retinopathy as well. Like they'll have history of retinopathy. If they do not, then that's not classical. So you will have to do a biopsy. Okay? Just keep this one in your mind. For type 2, they're very chill. Type 2, khalas. Type 2 is more severe. So what you're gonna do is the minute you diagnose him, you screen him, and then a year later you keep screening him. How do we screen? We screen with this test, a 24-hour urine albumin to creatinine ratio. And of course, you look at the GFR. Now, for management, of course, this goes without saying, you have to give them metformin to increase their insulin sensitivity. You give them as well the SGL2 inhibitors, so you decrease the glucose reabsorption in the kidney. And the most important part, like this is the only medication I genuinely want you guys to remember, is the RAS blockade medications. There are two, ACE inhibitor and ARBs, because they have a protective mechanism against diabetic nephropathy. Okay, very important. And these medications happen to pop up a lot, even like as we progress with the content of the slides, they're very important. Okay, they're gonna pop up a lot, so you have to remember them. Like now, moving on to hypertensive nephropathy. Now, there's two ways, okay, that a patient with hypertension is gonna come to present to you with end-stage renal disease. First way is the glomerular way, just exactly what happens in diabetes, right? The pressure, the interglomerular pressure is going to increase, or they're going to have interglomerular hypertension, hyperfiltration rate, protein leakage, and then eventually they're going to have end-stage renal disease. Other pathway is that because of the hypertension that's going on, right, their arterioles are going to undergo hyalinosis and wall thickening just to resist the pressure. Okay, so this is what we call nephrosclerosis. They're going to have this thing called nephrosclerosis. Okay, so imagine with me that you have a kidney, right? And a kidney is such a viable product, a viable organ, sorry. So if you try to stop blood from flowing into it, it's going to have ischemia. Okay, it's very sensitive to ischemia. So what you're going to have decrease in GFR and tubular atrophy. And even with time, you'll see that the kidney is going to shrink. So this is how you have end-stage renal disease in both ways under hypertensive nephropathy. Okay, but how do we diagnose? The patient need to have a history of probably uncontrolled hypertension. They also need to have some sort of organ damage. Okay, they'll present to you with mild proteinuria. You will of course diagnose. You need to do the urine albumin to creatinine ratio, because this will tell you where they are amongst the chronic kidney disease. And you'll also do a renal ultrasound, all right, which is going to show you a small kidney. Now, this is usually unusual, when it comes to chronic kidney diseases, that you have small kidneys, but in hypertensive, because they will undergo ischemia and tubular atrophy, this is basically what's going to happen. Okay, like how do we treat? We treat these people ACE inhibitor and ARBs. Very, very, very important. It's aslan a protective mechanism. How? It will dilate your efferent arteriole, reducing the pressure within the kidney, all right, and decrease the proteinuria. That's number one. Second thing that you guys need to keep in mind, you need to keep the blood pressure below or less than 130 above 80. Okay. You can also give calcium channel blockers like amlodipine. You can give diuretics if the patient's having like a lot of fluid, which is causing his hypertension. And of course, you need to consult the patient and tell them that you need to stop or like minimize sodium intake. Okay, like you need to tell them that they don't need to eat a lot of nuts, they don't need to eat a lot of fried food, so you basically advise them. All right. Now, obesity-related glomerulopathy. So honestly, this is the first time I read about it in your slides. And basically what happens is that when you have a lot of adipose tissue in your body, you're going to have this immense production of leptin, angiotensin 2, and pro-inflammatory cytokines. Okay? This is going to increase the metabolic demand in the body, which will lead to glomerular hyperfiltration. Okay, that's important. Now, how do we diagnose? We diagnose by doing a biopsy. You will actually see that there is kidney enlargement, and you will see something that we call as the focal segmental glomerulosclerosis. Why? This is because of the just increased demand on the kidney with this hyperfiltration going on. With time, it's going to cause this glomerulosclerosis. And I've attached a picture for you here. This is how it's supposed to look. Okay, so this is how you diagnose it. Now, how do we treat these people? Of course, we give them the ACE inhibitors, we give them the ARBs, you know, uh, protective mechanism for the kidney, of course. But the best and the definitive treatment is weight loss. All right, so keep that in mind. Like lupus nephritis. Where do we see lupus nephritis? We see lupus nephritis in SLE. Tamam. It's very common. Around like 40 to 50% of people who have SLE are going to have lupus nephritis. طيب. طبعا there are stages for lupus nephritis and you are expected to know all of them. تمام. This is going to haunt you as well in fourth and fifth year. So the first stage is what we call the minimal mesangial stage. Now here you're basically going to have normal kidney under the light microscopy. However, you're going to start seeing these immune deposits within the mesangium under, immunofluorescent light or electron microscopy. In this stage, صراحة, you don't need to do anything because the patient's not complaining of anything. You don't need to do anything. Second stage, which is the mesangial proliferative stage. Here, from the name, right, it's proliferative. So you're going to see hypercellularity within the mesangium on light microscopy. And the patient will present to you with mild proteinuria and hematuria. In the third stage, okay, it's going to become focal. So focal means like localized. So localized, basically around less than 50% of your glomeruli is going to be affected. And the patient here is going to present with you with, prominent hematuria, proteinuria, and even high creatinine levels. So here you have to start treatment and you have to treat aggressively. Okay. Fourth and fifth, like these are very severe. And this is, and actually fourth is the most common one in the proliferative class. Patients are going to present to you with more than 50% of their glomeruli being affected, and they'll have this wire loop lesions on light microscopy. Very heavy proteinuria, very heavy hematuria. They can also have some sort of hypertension and low GFR. The membranous one, okay, is going to be, you're going to have subepithelial deposits, which will cause, again, severe nephrotic syndrome. Now, why I've highlighted them in red, these tend to have very poor prognosis, okay? Which is why in patients who have SLE, you have to keep screening them for lupus nephritis, okay? The last stage is glomerulosclerosis. Now, خلاص, it's the kidney is undergoing sclerosis, okay? Here, the patient is going to have end-stage renal disease, all right? Your best bet is doing dialysis and renal transplant. Giving them immunosuppressions are not going to benefit. Tamam? Okay. Honestly, I don't expect much questions from this one, but yeah, you need to be able to understand the different classes. Okay. Like, how do we diagnose lupus nephritis? It's genuinely like you diagnosing SLE. Usually in the question, they're going to tell you the patient has SLE. How do you know the patient actually has SLE? So sometimes the questions are going to be like a bit, a bit tricky. So you have to know they're going to be ANA positive, they're going to be anti-dsDNA positive and anti-SM positive. All right. Now, which one is the highly sensitive one? ANA. And which one is very specific to SLE? Anti-dsDNA. Very, very important. You have to know these. طيب. And usually they're going to come to you with very low complement levels. And if the question described, like if the clinical scenario described that there's a patient who's been having multiple spontaneous abortions, right? خلاص. What clicks in your mind? Anti-phospholipid antibodies. تمام? And usually she's gonna have, and they tell you that she has very low GFR. She's been having proteinuria, hematuria, and stuff. Plus, you will think that she's a patient who has SLE and is having lupus nephritis right now. Like, if the patient is having symptoms of a acute kidney injury, right? Having proteinuria and stuff. When do we do a renal biopsy? When you cannot explain why this is going on. Okay, this is the only time you'll do a renal biopsy. تمام? For unexplained AKI, if they also have proteinuria, طيب, more than 0.5 grams per day, and if they also have any dysmorphic RBCs. Okay, so the takeaway are these, very important. The antibodies, you have to know them. How do we treat? If you guys want to skip this slide and remember only one drug is going to be hydroxychloroquine. Every patient who has SLE needs to be on hydroxychloroquine. No questions asked. You guys don't even want to think about it. Hydroxychloroquine. طيب. However, as the disease progresses, there are things that you would add. Okay, like for example, in class 3 and 4, which is proliferative, it's a severe type of proliferative phase. Here, you would need to give the patient IV methylprednisolone, all right, in the induction phase with mycophenolate mofetil or IV cyclophosphamide. And after you've induced therapy, to maintain it, you will give the patient low-dose prednisone, mycophenolate mofetil, or azathioprine. Honestly, I don't think you guys are going to get questioned about this. Just keeping it here. The 5th class, you give them, now the ACE inhibitors, the ARBs, mycophenolate again, steroids. Why? Because the patient's having heavy proteinuria. You need to preserve the proteins, right? You need to prevent that from happening. And for cases that are refractory, you can give voclosporin or belimumab. Again, if I were you, I'm just gonna purely remember hydroxychloroquine. Okay, and when the disease progresses, right, it should make sense to you that you need to give steroids, okay, to decrease the inflammation and try to hinder the the disease progression. Tamam. Okay, so we're done with lupus. Now we move to ANCA-associated vasculitis. Now, this is an umbrella term for 3 diseases: microscopic polyangiitis, granulomatous with polyangiitis, eosinophilic granulomatosis with polyangiitis. You don't need to know all of these per the slides, but what you need to know is why it happens. So when we say ANCA is basically antibodies against your neutrophils. Okay, in a normal person who have neutrophils in their blood, flows smoothly. Person who has ANCA, what's going to happen to them is these neutrophils, all right, are going to have ANCA bound to them, that it's going to go and cause inflammation within the blood vessels of certain organs and lead to their damage. Hence the term vasculitis. Okay. Now, one thing that you guys need to remember off the slide is that they're going to have pauci-immune necrotizing crescentic glomerulonephritis. Very high yield, extremely high yield. Like all these 3 diseases are going to share the same finding: pauci-immune necrotizing crescentic glomerulonephritis. Okay. Like, how will the patient present? They're going to come to you coughing up blood. Again, remember, the blood vessels are being inflamed and damaged. That's number 1. Second thing, they're going to come to you with alveolar hemorrhage. And when you assess the kidney function, they're going to have rapidly progressing glomerulonephritis, which, by the way, if left untreated with it, it's a matter of days to weeks where they will start developing end-stage renal disease. How do we diagnose? We're going to diagnose them, of course. We look for ANCA levels and we do biopsy. And their biopsy is going to come back with negative immunofluorescent, right? Which means pauci-immune. Tamam? Just keep that in mind. How do we treat these patients? We start them on rituximab and have very high dose IV corticosteroids. Because, guys, this is not a joke. The rapidly progressive glomerulonephritis, it will actually progress rapidly to, end-stage renal disease. So you need to give them a high dose IV corticosteroids. And to maintain the induction phase, the maintenance is going to be rituximab every 6 months or azathioprine for a minimum of 2 years. Now, if the situation was really severe, where he's having severe AKI symptoms, or he's having diffuse alveolar hemorrhage, and his, creatinine levels are really high, and it's being involving more than 50% of the glomerulus, what you're going to do is plasma exchange. But it's really reserved for like the extreme side of, you know, uh, ANCA-associated vasculitis. Tamam? All right. It's very important to know how they present, so just keep that in mind. Now, we move to anti-GBM, or good bastard syndrome. It's one of my favorite syndromes to study, very easy. Basically, what happens here is that you're going to have these antibodies that are going to target your type 4 collagen. Where is this type 4 collagen predominantly, um, predominantly found? In two places, in your kidneys and your lungs. So the patient is going to come to you with hemoptysis and hematuria at the same time. Hemoptysis and hematuria. If you see the question, hemoptysis and hematuria, خلاص, it is anti-GBM good pasture syndrome. That's it. Now, the big risk factor is smoking. You need to remember that. And there's no certain, there's no specific time where the disease is going to come. It's bimodal. So either presents in their early 20s or a patient who's like 60 plus, and they can both present with anti-GBM syndrome. Okay. Now, when will the question actually give it to you that this is an anti-GBM syndrome? When they tell you that the deposits in the GBM of the kidney is linear IgGs. When you see this word linear IgG deposition, خلاص, it is good pasture syndrome. Okay, and of course, to look for it, you can do anti-GBM levels, and they're going to be highly sensitive. Okay, how do we treat? Again, you're going to treat it with IV methylprednisolone, cyclophosphamide, and here you give plasma exchange for 14 daily sessions. Okay, because this one, good pasture syndrome, can rapidly progress to end-stage renal disease. Okay, because you don't need that. Tamam. Prognosis depends on the stage the patient presents at. If he presents with creatinine levels less than 600, then that's good. If he presents with oliguria, if he presents with his, more than 50% of his glomerulus crescents are being involved, this indicates that this is more towards severe AKI. So it's going to be poor prognosis. And there's no much relapsing rates. خلاص, the minute you treat it, usually they're in successful remission. Unlike ANCA, they have a lot of relapsing rates. Like, let's say that a patient comes to you with both ANCA and anti-GBM positive. How would you treat these patients? So think about it. You're going to give them heavy immunosuppression, like heavy immunosuppression, and you're going to give them plasma exchange automatically. Okay, because خلاص, imagine these two in one patient. Disasters. All right? Okay. Moving on to sarcoidosis. Sarcoidosis basically usually affects the lungs. Okay. How it's happened? You will have the systemic immune trigger that will lead to T cell activation, which will lead to non-caseating granuloma, and usually in the lung. Now, what's going to happen? That sometimes this granuloma, okay, will just go directly into the renal interstitium. The minute it happens, you're going to have granulomatous interstitial nephritis, which will lead to fibrosis and tubular disruption, leading to acute kidney injury. Tamam? So it's just basically granuloma depositing in your renal interstitium, which will lead to it being fibrosed and dysfunctional. And basically, this will lead to very low levels of GFR. Okay. Now, this is the first pathway. The second pathway it can affect your kidneys is by this granuloma, okay, are going to have these macrophages that are going to express 1-alpha hydroxylase enzyme in like crazy way. And what's going to happen is going to go to the kidney and convert vitamin D into the active form of vitamin D, okay, which is the 125-OH vitamin D. Tamam? This is going to cause what? This is going to increase your calcium absorption, and this is going to cause severe hypercalcemia levels in your blood, and you're going to have also hypercalciuria. So how will this manifest in a patient who has sarcoidosis? in two ways. It's going to manifest by having a lot of stones in the kidney, and usually they're going to be calcium oxalate stones. So keep that in mind. That's number one. Second thing, this calcium is going to downregulate the aquaporin levels in the kidney, causing what? Causing nephrogenic diabetes insipidus. Okay, so there's two ways it's going to manifest: either stones or nephrogenic diabetes insipidus. Okay, how do we diagnose? You're going to look for the ACE levels. They're going to be elevated. You're going to look at the 125-OH vitamin D, which is the active form. It's going to be also elevated. Because the patient has very high levels of calcium, they're going to have low levels of PTH, okay, the parathyroid hormone. And this is diagnostic, okay? On chest imaging, they're going to have bilateral hilar lymphadenopathy, all right? This is diagnostic for sarcoidosis. So if you see in a question that they're having calcium stones and bilateral hilar lymphadenopathy, sarcoidosis, okay? And upon biopsy, they're going to have non-caseating granuloma, as I mentioned, with no caseous necrosis. And this differs it from TB. And of course, we can give them systemic corticosteroids. Now, for drug-induced acute interstitial nephritis, so basically there's nothing wrong with the kidney. However, the patient is taking certain drugs that's causing the patient to have what we call sterile pyuria. Basically, white blood cells in urine, no bacteria. They also have eosinophils. Eosinophilia is high yield, all right, and diagnostic for acute interstitial nephritis. So a patient is going to come to you with fever, rash, and eosinophilia. خلاص, acute interstitial nephritis. طيب. Of course, you're going to see a lot of inflammation in the kidney. You're going to see a lot of edema. There's a lot of tubular injury. Now, what are those medications that would cause the patient to have acute interstitial nephritis? They're the 5 Ps. The pain-free meds, NSAIDs. You know, NSAIDs, disastrous. They always do something. So chronic use, of course, of NSAIDs. NSAID, penicillin, or even any beta-lactam antibiotic. PPIs, protein pump inhibitors. So if a patient who is suffering from a long-standing GERD history and they're taking omeprazole, think about, drug-induced acute interstitial nephritis. Patients who are hypertensive or have probably congestive heart failure and they're taking diuretics, it could also cause acute interstitial nephritis. And lastly, rifampin. So this is the very famous mnemonic used. Now, in the slides, the doctor added something else, which is the immune checkpoint inhibitors, nivolumab and pembrolizumab, these two medications. How do we treat? We stop the offending agent. So we stop whatever medication the patient is taking, tamam. And if the renal function did not resume back to normal within 1 to 2 weeks, then you can give the patient corticosteroids. You don't have to give them anything when they present initially with it, okay? And that's really about it for drug-induced acute interstitial nephritis. Now, this is a very, very, very common clinical scenario that's going to come to you. A child who presents to you with palpable purpura, joint pain, abdominal pain. This is the triad. Okay, and I added this extra info so it will make sure that everything is inclusive and highlighted. But this is the very common triad. The minute you see joint pain, abdominal pain, and purpura in a child, this is your takeaway. خلاص, it's gonna be IgA vasculitis. Okay, so this usually IgA vasculitis is preceded by an upper respiratory tract infection that usually happens a week to 2 in advance. And then when you actually examine the patient and do urine analysis, you're going to find out that the patient has hematuria and proteinuria. All right. This is IgA nephropathy, very common in children. How do you treat? So this one is supportive. Okay, it's limited. You basically give them supportive care and it's gonna go away. Tamam? You don't really give them anything special. Tamam? Just keep that in your mind. All right. Now, moving on to hemolytic uremic syndrome and thrombotic thrombocytopenic purpura. So usually people get confused within these two diseases. Okay. Hemolytic uremic syndrome in general is more predominantly seen in children, all right? And is seen in children who have bloody diarrhea. Okay. Usually they're going to come to you with bloody diarrhea. Okay. They're going to definitely have thrombotic microangiopathy as well. Okay. This is all due to the E. coli strain that they get basically infected with. Okay. They're going to have pallor, they're going to have mucosal bleeding, they're going to have petechiae and purpura all over. They can also have hematuria, as I mentioned. This is all because of the E. coli. And they also have schistocytes on their blood smear. The thrombocytopenic purpura is more commonly seen in children and adults. And the very, very important distinctive symptoms and clinical signs is the neurological symptoms. Thrombocytopenic purpura usually will come to you with headache, confusion, even seizure, and high fever. Okay. Hemolytic uremic syndrome, they don't usually come with fever as much as TTP does. طيب. Now, why TTP happens? خلاص, here we understand in HUS it's going to be E. coli. In TTP, they have a deficiency of ADAM TS13. All right. Deficiency in that enzyme, which will lead to basically this von Willebrand disease, and they're going to have TTP as a result. Okay. Okay. So this is just me, basically summarizing everything I just said. A patient who comes to you with hemolytic uremic syndrome is going to have three things: microangiopathic hemolytic anemia, or MAHA. They're going to have thrombocytopenia, and they're going to have acute kidney injury. Okay, given that they're going to have high creatinine levels, they're going to have hematuria as well. So keep that in mind. Blood smear, again, is going to show schistocytes. They're going to have negative Coombs test, elevated LDH, not as much as important. We have two types of E. coli. Two types of hemolytic uremic syndrome, type 1 and the typical one and the atypical one. The typical one is due to E. coli. The atypical one is a genetic mutation in your complement system. Okay, so how do we treat this? We treat it with a drug that we call eculizumab. Eculizumab is an anti-C5 monoclonal antibodies, and this is for life. It doesn't stop, tamam? Or else it's just gonna go and keep on having these attacks to the kidney. Maybe with time it could cause failure. Okay, now moving on to TTP again, as I mentioned, ADAM TS13. Okay, and TTP, by the way, is a medical emergency. So you have to give them plasma exchange, you have to do corticosteroids, and you give them immunosuppressants. All right. Like, we're moving towards the end of this lecture. So now we have cardiorenal syndrome. Cardiorenal syndrome is basically when your cardiac manifestations and renal manifestations just happen to coexist at the same time. Okay, so we have 5 types. The first type is when you have acute heart failure. This acute heart failure, the cardiogenic shock you're going to have from, and the basically this fluid or buildup and stuff is going to lead to AKI eventually. Tamam? That's one thing. The second type is when you have chronic heart failure, which will lead to chronic kidney disease, okay, due to the nephrosclerosis, the very basically hyperfiltration going on, right? The third type is when you have AKI, okay, AKI, right? And due to the kidney dysfunction causing the electrolyte imbalance, causing this fluid buildup, is going to lead to an acute cardiac dysfunction. So the first two is actually the heart failure leading to these renal manifestations. Type 3 is the kidney leading to these cardiac manifestations. Type 4, same thing, chronic kidney disease leading to your chronic cardiomyopathy, like having left ventricular hypertrophy or having this sort of accelerated atherosclerosis. The last type is systemic disease that causes both, like diabetes, like amyloidosis, which will cause deposits in the heart, deposits in the kidney, or even sepsis. Okay. So basically, this is the pathophysiology that I just explained. How do we manage these patients? We need to, first of all, you need to understand that the only thing that will predict cardiovascular mortality is low GFR. It's an independent predictor. That's number one. Then you need to give them something that was going to decongest the body. So you're going to give them diuretics. Okay, that's number one. But of course, we don't overly abuse the diuretics. Okay, so you need to keep that in mind. We can give them as well CGL2 inhibitors, especially if they have a history of diabetes. All right, this will decrease mortality, decrease morbidity, and also decrease the CKD progression. Okay. Lastly, we give them sacubitril and valsartan. This is a combination of a medication we call Entresto. Now, what does it really do? You remember that we mentioned earlier that we have this thing in our heart that, in the ventricles, where if there's a lot of blood pumping, right, you're going to have these, AMP and BMP being released. Now, when your AMP and BMP being released, what is it going to do? Is going to go and activate the RAS so that خلاص, we have these extra fluid. I don't want it. Let it out. Tamam? So what happens is we need this, right? We need this to stay in our body. We give a medication that will prevent the breakdown of these AMP and BMPs so that this is basically going to decrease the stress on the cardiac system and on the kidney. And basically, it will just act like a diuretic, if you know what I mean. Okay. It's a very cool medication and also shown to decrease mortality as well in these patients. Hepatorenal syndrome is basically in a scenario where the patient has advanced cirrhosis, okay, the hemodynamics of the kidney is going to fail. However, the kidney as a structure remains to be normal. Now you'll be like, what? How? So in advanced cirrhosis, right, the patient is going to have this severe portal hypertension. And because of that hypertension, okay, nitric oxide is going to vasodilate the hell out of the portal system, causing this pooling of blood. So now I'm going to have less venous return. Okay, this is going to trigger my RAS. Remember, triggering my RAS is going to cause this intensive vasoconstriction of the renal arteries, and it's going to shut down your GFR. Now, patients are going to present to you usually with cirrhosis, ascites, and acute kidney injury, like low GFR, oliguria, high creatine levels. All right, and usually they're going to show zero response to, after 2 full days of giving them diuretic like withdrawal and volume expansion with IV albumin. Like they're not going to respond perfectly to you resuscitating them with fluids. All right. So this is when you know that, okay, this is not a problem with the kidney, right? It's just a systemic problem that's going on. So how do you treat this? You do give them IV albumin and you give them splanchnic vasoconstrictors like terlipressin. And this will reverse the hepatorenal syndrome in usually 50% of the cases. But of course, to treat this definitely and permanently, you need to do a liver transplantation. Tamam. Now, hepatitis B, yani صراحة, if you guys want to remember 2 things, you need to remember it will cause membranous nephropathy and you treat it with antivirals. And one other thing that it does not respond to steroids at all. Hepatitis B affecting the kidney, the kidney does not respond to steroids at all. Tamam? And also one other thing that you do not administer an immunosuppressant without antiviral coverage. You're just actually going to make it worse for the patient. Why? Because you're going to trigger this uncontrolled hepatitis virus replication. So again, membranous nephropathy, antivirals. Hepatitis C, usually in the question, they're going to tell you that the patient, in his kidney, they have this thing called mixed cryoglobulinemia. Okay, this is basically strongly associated with hepatitis B. Okay, and it's going to present again with this membranous proliferative glomerulonephritis. The patient is going to come to you with purpura, arthralgia, and peripheral neuropathy. طيب. Also, they're going to have an isolated low C4. The complement 4 is going to be low. And this is indicative that the patient could have hepatitis C virus cryoglobulinemia. You treat with antivirals. Tamam? For HIV associated nephropathy, it's a very aggressive form of the focal sclerosis in the glomerulus. They usually call it collapsing FSGS. the patient is going to present to you with heavy nephrotic syndrome, okay, could rapidly progress to end-stage renal disease. And on renal ultrasound, what's really distinctive for HIV patients, that the kidney is going to appear really bright, and usually it's going to be normal sized or a bit enlarged, which is unlike a chronic kidney disease findings. Like, how do we treat these patients? We treat them with retroviral therapy. Tamam, it's very important. Now, sometimes they usually give the tenofovir desoproxil fumarate therapy. Now, this is, it can have some toxicity. And the very common side effect is the Fanconi syndrome. So Fanconi syndrome is basically one of the conditions where the kidney is going to have tubular acidosis, okay? And they usually will have phosphaturia and glycosuria as well, which means phosphate in the urine and like glucose in the urine as well, okay? COVID-19, now from this slide, they're just genuinely telling you that patients who happen to have AKI, okay, are usually admitted to ICU, okay? So this is something that you guys need to keep in mind. Now you'd be like, wait, how these patients in ICU, 40% of them happen to have AKI. Usually they have injury to the ACE2 receptor, causing the acute tubular necrosis, or it could be complement-mediated microangiopathy, or it could be collapsing FSGS, which is seen in HIV. Now there are some conditions, tamam, that are associated with tumors, cancer, okay, which definitely will lead to glomerulonephritis in a patient. What are they? The first one is your carcinoma-associated membranous nephropathy. Now, in this one, you need to remember two things. You need to remember that it's usually PLA2R antibody negative, and it's usually a cancer that the patient is going to have, which will only trigger paraneoplastic membranonephropathy. Low yield, honestly. But I put it here just for the sake of inclusion. Then you have this thing called lymphoma-associated minimal change disease, strongly linked to Hodgkin lymphoma. So this could become like a potential MCQ. Now, this one is really important, the tumor lysis syndrome. So usually we have these patients who have these very progressive and very severe kind of tumors, like Burkitt lymphoma, acute lymphoblastic leukemia, okay? And then we give them a medication, right, for, just to like shrink the tumor, okay? And sometimes when you go and give these medications so that it breaks the tumor, lyse it down, what's going to happen? All the contents of the tumor, including potassium, sodium, all the intracellular structures are going to now leak out and flush your bloodstreams. Okay, so imagine with me all these electrolytes, right? Thousands and hundreds of them in like large amounts get to go and obstruct the kidneys, leading to acute tubular obstruction, and could even manifest as severe form of acute kidney injury. So it's that severe. You need to keep that in mind. Also, patients who take chemotherapy could have some sort of nephrotoxicity, and this is common in 3 drugs. First one, cisplatin. You could get severe acute tubular necrosis. In ifosfamide, you get Fanconi. Just know that it has a lot of Fs, so it's going to lead to an F, so Fanconi. And bevacizumab could lead to hypertension and TMA, okay, which is thrombotic microangiopathy. Tamam. Multiple myeloma. Multiple myeloma is a very, very commonly tested disease. Basically, what happens is that you have an IgG that's being overly produced, tamam, which will lead to 4 clinical manifestations: hypercalcemia, renal insufficiency, anemia, and bone lytic lesions. Like, you're gonna literally see a bone, usually a skull, with like punched out lesions, okay, because it's being eaten out, tamam. And usually to diagnose a kidney myeloma, you need to what? You need to do urinalysis for Ig light chains, or the Bence-Jones proteins, تمام? Not a urine dipstick. Urine dipstick is more for like glucose and blood and stuff. Okay, it's going to be a negative urine dipstick. This is the doctor like, extremely emphasized on this point. تمام? And a further thing that might pop up in your questions, in your clinical scenarios, is that it will tell you that the bone marrow biopsy showed more than 10% of monoclonal plasma cells. This is a giveaway that this is a multiple myeloma. تمام? So in a myeloma kidney is a complication of multiple myeloma. What really is myeloma kidney? Basically, you have your distal tubules in the kidney, and you'll have these TAM horsefall proteins depositing there, and it's going to cause an acute kidney injury. Now, how do we manage? We give them a lot of fluids to flush out the tubules of all the deposits, and we correct the hypercalcemia because they could develop stones right in the kidney. So we need to immediately correct that, and then we need to treat the myeloma. So we can give dexamethasone, we can give bortezomib to stop the production of these light chains, all right, and for them to not go and deposit in the kidney. Then we have amyloidosis. Now, we have two types of amyloidosis. The first type is a primary type of amyloidosis, where you have these monoclonal light chains going and depositing in the organ. The second type, you have these serum amyloid proteins that are being overly produced due to this chronic inflammation, and they will go and deposit in organs. So it's two ways. So it's either a monoclonal light chain going and depositing in an organ, or we have this chronic inflammation going on, and SAA, which is a biomarker for inflammation aslan, will go out and basically deposit in kidneys or whatever organs. Tamam? So both types are going to lead to nephrotic syndrome. So you're going to have this immense proteinuria, right? And with time would lead to progressive, chronic kidney disease and then end-stage renal disease. Like, how will you know that this patient has a primary amyloidosis? Usually they're going to have huge tongues. So they're going to have macroglossia with dental indentations. That's number one. They're going to have raccoon eyes. So they're going to have basically like purpura periorbitally. They're going to have bilateral carpal tunnel syndrome. So usually the scenario, an older adult will come to you complaining of مثلا the acute kidney injury symptoms, and you will find an MSK report that says that they have bilateral carpal tunnel syndrome, like they have numbness, wherever the median nerve gets to supply the hands. So that's a giveaway that this is primary amyloidosis. Okay. How do you diagnose? You give them Congo red stain. It's going to turn apple green birefringence under polarized light. And basically, you can give them chemotherapy and autologous stem cell transplant. Like, this is for the primary one. For secondary one, you treat the underlying disease. It could be rheumatoid arthritis, could be inflammatory bowel disease, whatever it is, you go and treat the underlying disease. Tamam? But according to the doctor, and he's probably more emphasizing the primary one. So this is what you really want to remember. And we're done with the lecture. It's very heavy, I know. Is you have to remember all these things. You never know what you could get. You could actually get tested on. Now, geriatric medicine lecture is very easy, inshallah. First of all, you need to understand that part of the normal aging, organs at one point they're gonna slow down. Tamam? Organs are gonna slow down. Their function is gonna decrease a bit. Okay, so it's normal to have abnormal findings that you think a 20-year-old is not going to be the same as a 70-year-old. So that's something you need to keep in mind. One thing that stays constant, though, is the function. Okay? If the functionality of a human is declining, that's not normal aging. Okay? So the function should not be impaired with normal aging. This is extremely important for you guys to understand. Now, let's talk about cognition a bit, because it's a very high yield topic when it comes to aging, right? In cognition, we have two types of memory. We have the long term and the short term. Long term is like the skills you've attained, the vocabs that you know. Like if I go and tell a 70-year-old, where were you born? Okay, if I go tell them, like Do you remember, for example, lyrics to your favorite song back in the 20s? They'll be able to reply. But if I tell them that, if let's say, for example, I tell them that, we're having a conversation and let's say I said a new word, 5 minutes later, it's normal for them to forget it. Like their short-term function is going to decrease a bit, like their attention, recall, and working memory. It will decline. But this is not dementia. You need to keep in mind this is not dementia. This is part of normal aging. Okay. So, what are the other things in normal aging? Lauren, this was found in your slides. I don't understand why it's there. We're going to go through it quickly. First of all, when we're going to talk about the heart, you need to understand that the patient is going to have, decreased number of SA nodes. This will put the patient at risk for bradycardia. طيب? So this is number one. Number two, their pulse pressure could get widened. Okay, so they have more now. They have more risk for like AFib and stuff like that. So these are part of normal aging. طيب? That's number one. Number two, we have now the respiratory system. Respiratory system, you need to understand that their dead space is going to increase, right? They're going to lose the elastic recoil. So their chest wall compliance is going to decrease. So it's going to be more difficult for them to get these deep breaths that they used to get when they were younger. Okay, that's number one. Sorry, that's two. Three, when we come to renal, okay, which we're going to discuss show you more now in advance, patients are normally going to develop a slight decrease in their GFR, like after the age of 40 onwards. The creatine production will also decline, and they're also going to have decrease in the activity of the 1-alpha hydroxylase enzyme, which means reduced active form of vitamin D. So they're going to be more prone to having vitamin D deficiencies. Okay. Then you also need to understand when it comes to their urinary system, they're going to have this decreased bladder activity, decreased detrusor activity. So now you need to think more of what you need to think that these patients will, more likely they're going to develop UTI. And by the way, UTI is very, very, very common when it comes to elderly patients, due to bladder retention. Okay. Men could have increased prostate size, so they could have prostate cancer. So we also need to think of that. But of course, they need to suffer from the prodromal signs, like, dribbling of urine, hesitancy, urgency, and all that, right? When it comes to GI, they're going to have constipation. And constipation is very common in elderly, okay? MSK, of course, you're going to have decrease in bone density. They're having decrease in their muscles and the force of the muscles. So usually they're going to come to you with falls, recurrent falls as well. So that's also something. Neuro-wise, you need to remember that their reflexes are going to get slower. That's number one. They're going to have reduced sensation, which may or may not trigger depression in them. They're going to lose balance a bit. Their speed of processing things are going to decrease as well. And that comes to motion and cognition, both. Okay, so this is what really I want you guys to take away from this slide. Now, pharmacokinetic changes. Now, there are four aspects, four dynamics you guys want to think about. The first one, and the most important one, is renal elimination. It's going to be reduced, which will precipitate to you guys clinically as decreased GFR. Why is this important? This is important because there are some medications that you have to give for elderlies, like, for example, digoxin. Digoxin is a toxic medication. By the way, they stopped using it often now. But imagine you're giving this patient digoxin, and the elimination process from the body is reduced. So this means that the metabolites of this medication is going to be more likely to be built up in the blood, tamam, which will lead to their toxicity effects, more prominent in these patients. So this is number one. This is something you guys want to think about. Second thing you guys want to think about is the metabolism. So imagine if their elimination is hindered and their metabolism is also affected. Why? Because the liver, with time, the mass of it is going to shrink a bit, and the blood flow to it is going to decrease, especially if these patients have history of atherosclerosis. okay, or like some sort of heart condition. Tamam. Why is this important? Because there are some medications that their metabolism and for them to be effective rely heavily on the liver, like amlodipine, diltiazem, thiophyllin. All right, so these are very important for you guys to think about. Distribution is also impacted. How? So you need to think that the fat-free mass is going to decline. So all the muscles, organs going to shrink, right? However, the body fat is going to increase in elderly patients. So what's going to happen is distribution of hydrophilic drugs are going to decrease, and distribution of lipophilic drugs is going to increase. Okay, because fats is more available now. So a medication that's lipophilic is more likely to be distributed, more efficiently compared to hydrophilic drugs. Lastly, absorption. Absorption is not affected, however, it's slowed. Okay, why? Because there's decrease in the function of the ventricles, decrease in the function of the intestines, and less blood flow to the intestines as well. So the absorption is going to be slowed. Right. So we need to be very careful with what medications we give, tamam, to elderly, because usually elderly are going to have some very common diseases like dementia, Parkinson, peptic ulcer disease. So we're going to go through these. Tamam. If you give a patient who has dementia an anticholinergic drug, you're putting them at a very high risk of them developing delirium. So they're going to get confused, and they're going to have this, basically this episode of delirium. If you give a patient antipsychotics who have Parkinson's disease, you're going to worsen their tremors. And same goes, if you give a patient aspirin and they have peptic ulcer disease, you're going to cause bleeding. Patient could die. If you give a patient who has congestive heart failure calcium channel blocker, you're worsening their heart failure symptoms. They're going to come to you again with this severe dyspnea, shortness of breath, dizziness. All right, they could even enter, delirium, confusion. Okay, a patient who have decreased renal function and you give them NSAID, you kill the patient. You give him خلاص هيصير renal failure. طيب. Again, same thing goes for heart failure. It will worsen your heart failure if you give them NSAIDs. If you give a patient thiazides who have gout, you're going to worsen their condition. And if you give a tricyclic antidepressant to epileptic patients, you're going to lower their seizure threshold, which means that, they're going to have like easier seizures. All right. So you guys need to keep this in mind. Like probably you're going to get an MCQ on this. A patient 70 plus, they have, for example, peptic ulcer disease, which medication you want to avoid. Or they're going to tell you that, let's say this patient, he has congestive heart failure and he's been treated. And recently he came for a follow-up and you realize that, they're complaining of, body pain. Okay. And they also got like an upper respiratory tract infection. And then you decided to give them an NSAID. What would happen? Is this okay? Is this not okay? Or for example, you're going to tell you the patient's symptoms worsened. Why did it worsen? It was because of the NSAID. Okay. Like for functional assessment, when we're assessing functionality, there's two ways we assess. We have the basic life needs, the bare minimum things that you need to know to survive life. And that's the basic ones, like dressing, grooming, using toilet, transferring things, eating, bathing. These are all basics. If a patient starts to have a physical decline, they will lose their basics, the BADLs. That's number one. Now, instrumental things that accessories to life, like medication management, finances, driving, cooking, cleaning, shopping, etc. If they start losing these instrumental functionality aspect, this means that the patient starts to have early cognitive decline. So they could probably have dementia, Alzheimer. So this is how you will differentiate it. Okay, this is صراحة the only clinical significance from this slide. Okay, now delirium. Delirium is very important, very commonly seen in elderly. But usually people misdiagnose it for dementia. Okay, so there's a criteria for us to follow to diagnose delirium. First of all, we need to have disturbance in attention. They do not have the full ability to be focused on you, okay, and they're not going to be able to have their full awareness to whatever you're saying. So they're going to have reduced orientation to the environment. They're going to look confused, tamam, and whenever you're talking to them, they're just going to cut the talk and start doing something else. Okay, that's number one. Number two, short period of time. Very, very important. Okay, this is actually one of the things that differentiates it from dementia. Dementia is something chronic that develops with time. Tamam. Delirium, something that happens acutely, due to a trigger. So usually hours to a few days, and it fluctuates in severity. It's very, very important. This criterion is very important. Second thing that you guys want to know is that there's going to be disturbance in their cognition. They're not going to be cognitively intact, meaning they're going to be disoriented. They're going to say things you guys are not going to understand. They're going to have memory deficit. They can't remember what they did yesterday, for example, or 2 days after. They might be confused and they do not even know where they are. Tamam. Fourthly, you need to understand that whatever disturbances they had to their attention and awareness and cognition do not need to be explained by any other pre-existing neurocognitive disorder. Tamam? This is very important. They need to be neurocognitively free, or at least whatever they have and related to their neurosystem does not need to impact their attention, their awareness, and their cognitive abilities. Okay. Lastly, we look for a disturbance that happened that directly impacted, their condition, which led to delirium. Like, for example, did we give them too much medication of something? Or are they in pain? Did they have UTI that we didn't know that led to sepsis, for example, that caused, delirium? Were they exposed to a certain toxin? So what will help us is, a mnemonic that's called dimers. All right. Delirium is not a diagnosis. It's a symptom of an underlying trigger. You need to keep that in mind. You can't just come and tell me, oh, the diagnosis of this patient is delirium. No. There's something that's causing the patient to have, this reduced attention, awareness, and, cognition function. So this is what we go with. This is the mnemonic that we go with. First of all, we can have drugs. Drugs, like, for example, the patient could be taking some certain drugs and he's going to drug withdrawal. He could have delirium. Very common, like patients who are depressed and they're taking SSRIs, they could have delirium and in withdrawal. Excessive use of certain medications, like if you give them a lot of benzos, a lot of opioids, they could have delirium. Or if they're suffering from some sort of physiological pain, all right, and they're not prescribed enough dose to treat this pain, they could also have delirium due to the pain. Infections. So when we talk about infections, I want you guys to remember 3 infections when we're talking about elderly. Okay, pneumonia, UTI, and skin infections. Very common, extremely common. Okay, especially UTI. I can't stress this enough. Then metabolic, like if, for example, if the patient is hypoglycemic, or he has low cortisol levels, or whatever any other metabolic disturbances they have, they could lead to delirium. Environmental, so they could be sensorily overloaded. Maybe they're going through something at home. Maybe they're isolated. Maybe their schedule, their routine is disrupted. They're not having enough hours to rest and sleep properly. This could lead to delirium. Because, think about it. The older someone gets, the more you need to be treated like you're taking care of a child. Okay? Because any disorder in their routine, in their day, could lead to some sort of agitation. All right. So this could also probably lead to delirium. Fourth, retention, right? Probably they're having, some retention of urine in their bladder, which would lead to, infection, sepsis, whatever. So you need to do a bladder scan, abdominal x-ray as well. Could be structural abnormalities. They could have like stroke. They could have like subdural bleeding. They could probably have constipation. They could probably have some sort of, any COPD or any other pathologies in their lungs. Okay. Now, a question that you guys might get as an SAQ is when a patient has delirium, when is it indicative that I go and get them an MRI done or any neuroimaging? You have to know these. When a patient has a focal neurological deficit, like for example, he's having numbness, paresthesia in their hands or their legs, all right, or they can't feel half of their face, they can't smile properly, indicating stroke, you'll do it. If they have reduced consciousness, okay, which in our case they do, so you need to do it. If they had a history of a fall or head trauma, you have to do a neuroimaging. You need to rule out, hematomas. You need to rule out intraparenchymal bleedings. That's something you're going to do. If they're on anticoagulants, why? Because it's going to put them at higher risk for bleeding. So you have to do it. And if they had a fever with any acute brain findings, then you need to do a neuroimaging. And if you're out of options, you cannot understand why this patient is having delirium, then you do neuroimaging as well. Okay. Now, how do you treat them? Usually, the non-pharmacological management is the mainstay of delirium. Do not just go and be like, oh, khalas, you know what? This patient is, having these episodes. We're just going to put them on antipsychotics. No. You start with non-pharmacological managements. So what are they? First of all, ABCs. You need to consider, is the patient stable or not? So that's something that you want to go ahead and do. Okay. That's number one. Number two, you want to give them thiamine. But before thiamine, you need to check their glucose levels. You need to give them naloxone, all right, oxygen, glucose in case they were hypoglycemic. So you need to make sure if they were unstable, you stabilize the patient. That's number one. Number two, you try to look for the contributors, the triggers, and treat it. Three, you give supportive care. Okay, you support whatever pain they're going through, you do it. You only give antipsychotics if the patient is dangerous to himself or herself and to others. And if they're having any distressing psychosis episode, you do give it. And if it is something that is going to prevent medical condition from happening, then yes, you go on and do give it. Okay. And if you decide to give an antipsychotic, you either give haloperidol or you give an atypical antipsychotic. Okay, that's the first line. So, yep, to make sure that it's safe and not that toxic. Now, geriatric depression. Depression is very common in elderly, especially if they're not getting enough attention, especially if they're alone or their spouse is dead. They will get depression, and it could just be as simple as like sadness, right? Or it could be like pain. They could come to you with this unexplainable body pain, right? You don't even know what's going on. You do everything and you cannot find out why the patient is having these body pains, for example, okay? Or it could be cognitive or what we call pseudo-dementia. So what do we mean by pseudo-dementia? It's you get these cognitive symptoms of depression from decreased frontal lobe activity. Like, for example, usually when you're questioning them and telling them things, asking them things, they're gonna be like, I'm tired, I don't know, they're not gonna answer, they're not gonna engage with you. All right, so this is pseudo-dementia. Why pseudo-dementia? Because people who have dementia, they're gonna try their best to minimize the error, all right, or maybe they're gonna confabulate, just say whatever, just to give you the idea that I'm fine, all right, I'm not going through anything. Like, on the contrary, in geriatric depression, no, they're just gonna give up. They're gonna give up on you easily. They're gonna I don't know. Okay. Now, suicide risks in geriatric depression is not that high. It's not very frequent. Okay. But they have a higher completion rate that they proceed and complete it. They just don't I just want to kill myself, and they basically stop from doing it. It's low frequency, but if they do it, they're gonna do it successfully. Okay, and they don't usually have that high risk of suicide, by the way. So any patient, and usually these patients come to who? They come to their family medicine doctor. Okay, and also in family medicine, you have to screen every single patient who comes with the screening tools for depression. So a patient who you suspect will have depression, you need to screen them with the tools. What are the three tools? PHQ-9, which is I think patient healthcare questionnaire, PHQ-2, and geriatric depression scale, which is a 15-item scale. The most commonly used one is the PHQ-9 and PHQ-2. Okay. طيب. Let's say خلاص, you confirm that this patient actually have geriatric depression. How will you treat this patient? First of all, your first line, sertraline and duloxetine. Okay, and usually sertraline is your option. Second line will be citalopram or escitalopram. However, these both carry a risk for QT prolongation. So if the question says that the patient has a history of a cardiac disease, AFib, and all that, you do not give these medications. Okay? You can give something else like venlafaxine, venlafaxine, all right? This is a good medication, okay? However, this medication could lead to insomnia and weight loss. And remember, we need to be very, very delicate with how we treat our geriatric patients because anything that would disrupt their routine could, worsen their depression. Tamam? So if they have a history of anorexia or their BMI is already like less than 18, then I wouldn't go and give them venlafaxine or metrazapine. All right. So you just need to keep that in mind. Vortioxetine is usually commonly used as well. All right. Now, the third or your fourth line, if everything happens to fail, you go for tricyclic antidepressants. However, we always avoid these. We even avoid them in adults. Why? Because these have severe anticholinergic properties, and you do not want that for your patient, especially because usually geriatric patients are going to come to you with a lot of comorbidities, and they can cross-match, and you don't want that. Tamam? So you keep that in mind. Okay, what medications you avoid? You avoid fluoxetine, number one, because usually people think, خلاص, depression, I'll give fluoxetine, because it's one of the most commonly prescribed antidepressant drug for adults. صح? Fluoxetine, خلاص. You're depressed, take fluoxetine. There are memes about fluoxetine. So in elderly, you do not. Why? Because they, again, remember we said their metabolism is going to be, slowed down, impaired and stuff. They're going to have prolonged half-life. They're going to stay more in the blood, so more chances of toxicity. We don't want that. Paroxetine, highly anticholinergic. I don't want it. Monoamine oxidase inhibitors, they can have dangerous interactions. They're even dangerous in adults. And I think they're not prescribed anymore, except in refractory cases. So generally try avoiding these medications. These three, avoid them when it comes to treating a geriatric patient who's suffering from depression. How often do I need to reassess these patients in my clinic? A patient who's old, depressed, tamam, how often do I need to see them in clinic? So I should see them every 1 to 2 weeks for 10 to 12 weeks. Why? Because these patients are at higher chance of developing side effects. These patients could not be compliant. And I also, after 10 to 12 weeks, I want to see if, they get to improve, tamam, or I need to change my regimen, all right? So in case this comes as an MCQ, here you go. Falls. Elderly adults, usually people who are at the age of 65 and above, usually are going to present to you with a fall. Tamam? 33% of them, extremely common. Tamam? And when they fall, they could have fractures. Okay, they can, for example, have their hip being fractured. They can have a femur fracture. They can have, fractures in their upper limb as well. So it's a very, very common scenario seen in geriatric medicine. Tamam. Something that you guys want to know, the definition of recurrent fall. So when I say that this patient has history of recurrent fall, what do I mean? I mean that they had 2 or more falls in the past year or the past 12 months. So if I tell you that the patient fell today, and then 6 months later, he presented with another fall, is this considered recurrent fall? Yes, it is. And they have their own protocols to follow and stuff, all right? Diabetes in older adults. Now, when we need to treat diabetes in older adults, remember, for example, in a normal adult, like young adults like ourselves, if someone who is suffering from diabetes, how do we treat them? of course, we treat them with medications, but what's our goal? Our goal is to make sure that we bring down their HbA1c. Tamam? This is our first thing that we think of. صح? In geriatrics, the first thing I need to think of when I'm treating them with diabetes, I need to keep in mind the risk of hypoglycemia. Okay? Because these patients could take multiple pills accidentally. These patients could, you know, do something wrong. So hypoglycemia, that's number one. Okay. Now, what medications I need to avoid in geriatrics? I need to avoid sulfonylurea. Why? Because they will put the patient at a very high risk to develop hypoglycemia. And I do not want that. Okay. And which category of the geriatric patients who will suffer the most? People who have declining renal function. Because this means that the sulfonylurea is going to build up in the blood. And I don't want that as well. All right. Like, now, what are the medications I can give to a geriatric patient who has diabetes? Metformin. We can also give DTP4 inhibitors, tamam, CGL2 inhibitors, and long-acting insulin in case if their HbA1c is like above 11, tamam. But your first line is metformin, okay? Now, when you need to give them GLP-1 receptor, agonists, you need to be very careful that it causes weight loss, prominently weight loss. So if the patient was frail, you do not want to do that, tamam. And if the patient is someone who is at high risk of dehydration, maybe due to an ongoing disease that they have, you wouldn't give them SGL2 inhibitors, tamam, because it's gonna just worsen the dehydration. Okay, like, of course, now when I want to make sure that the patient their hyperglycemic index, when we want to assess it, right, we look at the HbA1c. Now we know that, for example, in adults, anything less than 5.2 is considered good, right? So how do I know, or how do I assess it in geriatrics? It's not the same. We depend on what? We depend on their functional status and life expectancy. So if the patient is functionally independent, tamam, I am happy with an A1C less than 7 or equal to 7. If they are functionally dependent, tamam, we can look at a range of 7.1 to 8. All right? Because anything less than 8, they could, or actually, no, 7.1 to 8. That's it. Tamam. If the patient is frail or exhibits signs of dementia, I will look at 7.1 to 8.5. And if he's at the end of his life, we're going to avoid any symptomatic hyperglycemia and hypoglycemia, and just make sure that we provide the right palliative care for these patients. Okay. So what you really need to keep in mind is that we do not look at it as like from a generic POV. One size does not fit all. It really needs to depend on their functional status and life expectancy. Okay. Like polypharmacy, the slides did not define what polypharmacy is or the impact on geriatric patients. However, I'm just going to tell you a few things in case they pop up. Polypharmacy is basically when you give multiple medications at the same time to a patient. And usually people who are, old, they have comorbidities, and they usually take, believe it or not, 15 to 20 medications in a day. Like this shouldn't be happening, tamam, because this will impact the patient's kidney, impact the patient's heart. Some medications could cross match and either worsen the situation of a patient, so we wouldn't want to do that as well. Okay. Now, what the slide had mentioned, that there are some certain indexes and criteria you can refer to evaluate the prescriptions of these patients, okay, to make sure that there's no any drug-drug interaction, to look at efficacy as well, all right? So these are the ones that they mentioned, and they also mentioned some other research papers. So this is the medication appropriateness index and the stop-start criteria. This is, honestly, I don't think you guys are going to be tested on this, but in case it pops up as an MCQ, here you go. Constipation. constipation is not simple, all right, especially in adults. And if I get an adult, sorry, in geriatrics, and if I get a geriatric patient who has constipation, I'm probably gonna think that, you know, there could be some neurological triggers going on, maybe cancer, maybe medications. So I need to be very, very careful, and I need to look into this deeply, not lightly. Oh, you have constipation, just increase your fiber intake. No, you have to take it really, really seriously. So the first thing you want to look at is the medications. Because again, we know geriatric patients are going to be on a lot of drugs. Tamam. So first of all, you want to look at the anticholinergics. If a patient is taking an anticholinergic, it's aslan going to slow down your GI mobility. So you are expected to have constipation. If they're taking opiates is going to cause constipation. If they're taking iron supplements, calcium supplements, it's going to cause constipation as well. Tamam. Calcium channel blockers as well, and NSAIDs. These are all known to cause constipation. Okay. Now, other causes of constipation is immobility, because usually patients who are geriatric and old, right, they're not going to move much. They're going to have a very, very, very sedimentary lifestyle. They're going to be home all day. So usually, due to this lack of physical movement, their colonic peristalsis is going to decrease. So we usually tell them to go on walks. It's going to help. Second thing, neurological conditions. They can have some certain conditions that could lead to constipation. The most important one, in my opinion, is diabetes. Why diabetes? Diabetes is going to cause the autonomic neuropathy. So it's going to damage the neurons, that supplies the intestines, which will lead to constipation. Very common, all right? Volume depletion. Sometimes people who have this subclinical dehydration over a long period of time, they're going to have constipation as well. And metabolic derangements. And usually these come hand in hand. Hypothyroidism, hypercalcemia, and hypokalemia. Any of these three presented in a patient, you need to think that they could possibly have constipation. Okay. It could be a mechanical obstruction like a tumor, strictures, or impaction. Okay. Could be that the patient is, depressed, or could have dementia, or it could be probably their diet is poor in fiber. Okay. So how do we approach? First of all, we need to identify what are the symptoms. How often does he go to the toilet? Is there straining when he goes to the toilet? And does he feel when he's evacuating, right, feces? Is it complete or not? Tamam. And then after that, I want to look at the secondary causes that I just mentioned. Okay. Then I need to look at the fecal impaction. So I will do an abdominal X-ray, right? Or I can perform a DRE, tamam, to diagnose, especially if the patient has dementia or he's bedbound, he can't move. You would do these things because he could have fecal impaction. And if he does have fecal impaction, you could proceed and manually disimpact the feces. Okay. Then we need to tell them that when you want to use the toilet, you have to make sure that you're in a seated position with your knees, all right, are like above the hip levels, the level of the hip, all right, so it can ease defecation. Tamam. Patients who have cognitive impairment, what we can do is we can specify and allocate a certain time where they can go and use the toilet after morning meal. Why? Because after the morning meal, you'll have your gastrocolic reflex. So we could utilize that. So khalas, after their morning meal, they have an allocated time to go and use the toilet. Okay. Okay. Now, other things that we can approach is their diet. Okay. Especially if their diet is poor in fiber, we try to increase the fiber. However, we do not want to do some sort of fiber loading, especially if these patients are immobile, like bedbound. Why? Because it can cause severe impaction or obstruction. Okay, you need to keep that in mind. Now, let's say we tried diet didn't work. We can go and give them laxatives of their own choice. Okay, we can do that. Fourth thing we can do, if the laxative didn't work, we can take some other laxative agents, like for example, polyphenol glycol or lactulose. We can give it to them. Tamam. If that didn't also happen to work, we can combine and alternate certain laxatives, okay? Like magnesium bromide, docosahexaene calcium, synthesides, and enemas, all right? And we are done with the geriatric lecture. So the geriatric lecture, again, what you want to know is normal age, part of normal aging, functionality happens to be preserved. If it's not preserved, that's not normal aging, there's something wrong. That's something very important you guys want to know. You also want to know how to deal with diabetes in a patient who's diabetic, and old. It's very important. Tamam. Constipation, very important. Because these are like the most important parts of the geriatric lecture. Okay. Now let's move on and talk about shock and sepsis. Okay. So when we say shock, mainly the body is in shock, they don't know what to do, and they just probably would go into failure. What kind of failure? A life-threatening circulatory failure. Why? Because they have this tissue hypoxia that's going on due to reduced oxygen delivery, increased oxygen consumption, or probably inadequate oxygen utilization. Now, when we say shock, people usually think, oh, the patient is going to be hypertensive. No, usually they can be hypertensive. They can be hypertensive, or they can have normal tension. All right. So you do not need to wait to the patient to become hypertensive to diagnose him with shock. All right. If we able to catch it in early phases and intervene, initially it's going to be reversible. Tamam? However, if it goes to levels where you have organ dysfunction and sepsis, it could be irreversible. Okay, so that's something. Like, also, when someone is in shock, you have to look for signs of end organ damage, like altered mental status, oliguria, clammy skin, elevated lactate levels. All right, these are things you want to look for. So we have four types of shock. First of all, we have the cardiogenic shock. طيب. Cardiogenic shock is where your heart fails to pump properly. Why? Either the patient has an MI, or they have severe form of heart failure, or they have, for example, like severe form of myocarditis. Could happen. How? Basically, their contractility of the heart is going to decrease. So that's going to decrease your cardiac output and decrease, the blood reaching to the organs. So that's going to do what? It's going to trick the brain that, okay, we don't have enough blood, activate the RAS. You're going to have systemic resistance all over. All right. And this will basically just worsen your ischemia situation and you will enter this vicious cycle. So that's cardiogenic shock. Okay. Hypovolemic shock, from the word hypovolemic, there's less blood flowing in my vessels. This could be due to trauma, which led to hemorrhage, could be dehydration, a patient who's suffered from burns and lost a lot of fluids, or a patient who's been vomiting chronically. Tamam? So less venous return, same thing, less cardiac output, and then you'll enter this compensatory vasoconstriction. Okay. Third one is your obstructive. Something is obstructing, tamam, the venous return or the right ventricle outflow. Okay, something is stopping the blood going from the heart to the lungs. Okay, so this could be due to massive pulmonary embolism, could be due to a cardiac tamponade or tension pneumothorax. You will have a drop in your cardiac output, and then you'll enter the same vicious cycle. Last one is distributive. Distributive shock, basically here what's going to happen is the patient usually is going to be having sepsis, okay, or anaphylaxis. طيب. What's going to happen is that they're going to have this pathological vasodilation and inappropriate distribution of blood, right, which is going to cause tissue hypoxia. Now, a very, very common phrase that usually comes in scenarios is cold, clammy skin. Cold, clammy skin will be seen in cardiogenic, hypovolemic, and obstruction. Why? Because there's vasoconstriction. A warm skin is going to indicate that the patient is having a distributive shock. Okay, it's very important. Like, let's talk about hypovolemic shock. Hypovolemic shock, again, we know the causes, we just mentioned them. So it's basically when you have less fluid in the heart, in your vessels, less venous return, less stroke volume, less cardiac output. Now you're going to trick the body that, oh, I'm not doing enough, right? I need to pump harder, right? So what's going to happen? You're going to have tachycardia, you're going to have vasoconstriction, you're going to have your RAS system activated, okay? And it's going to overwhelm the tissue hyperperfusion, leading to further ischemia. So if you test the patient, he's going to have lactic acidosis and metabolic acidosis. And this could lead to progressive organ failure, and it happens really fast. طيب. Now, a patient who's bleeding, their hemorrhagic shock is divided to 4 classes, and it depends on how much blood they lose. So the first class, usually it's just like less than 15% of their blood composition. They'll have normal heart rate, their blood pressure is normal, respiratory rate is normal, neuro examination is normal, and we just observe, right? We just observe and see what happens. Class 2, they're going to have up to 30% of blood loss. They're going to have tachycardia, the beginning of tachycardia. Their blood pressure is going to be normal. They're going to have, some sort of tachypnea. They're going to start, being anxious. And here you need to intervene, all right, and give them crystalloids. Usually we give them lactate ringer, okay? Why crystalloids? Why lactate ringer? Because they're the balanced form of crystalloids. Keep that in mind. Class 3, when they reach up to 40% of their blood being lost, this is critical. From class 3 and class 4, this is critical, okay? So here you're going to have tachycardia, you're going to have hypotension. This is where you have hypotension right here, right? Tachypnea, the patient is going to be confused. So this means that the tissue hypoxia has reached the brain. Their lactic acidosis is building up, right? So here you have to intervene and give them crystalloids and blood, all right? Class 4, when it's more than 40%, this is severe hypertension, lethargic, patient could die. So you need to do a massive transfusion protocol, okay? And this is basically, in a nutshell, your hemorrhagic shock classes. Like, how do we manage? Initially, I need to stabilize the patient. تمام. ABCs. Always go back to your ABCs. طيب. Give IV access, volume resuscitation with lactate ringer, and try your best to bring the mean arterial pressure to more than 65. Okay. Definitively, you need to control and identify the source of bleeding. You need to give blood. And we also happen to give something we call tranexamic acid, which basically is going to vasoconstrict. Okay. Why do we give it? Again, to vasoconstrict, and we give it within the first 3 hours of the injury. And then there's a triad that you need to correct as a physician. 3 things: hypothermia, lactic acidosis, and coagulopathy. Because, when you're losing blood and, you can have some sort of stasis, the patient can start developing clots. So that's also something you need to keep in mind. Okay. So hypothermia, lactic acidosis, and coagulopathy. This is what fears any physician, all right, when it comes to hypovolemic shock. Then we have the cardiogenic shock, which I just mentioned. Your heart fails to pump enough blood to meet the tissue metabolic demands. Most common cause is your acute MI. Okay. Now, again, we know how it happens, right? The heart just fails to pump properly, and you're going to have this worsened ischemia, and it's a vicious cycle. It doesn't stop. Okay. It's going to vasoconstrict, and your tissue hypoxia is going to get severe and severe. Like, how do you know that the case is talking about a cardiogenic shock? First of all, you're going to have elevated JVP. You're going to have jugular venous distension. You're going to have crackles heard in your lungs, which indicates pulmonary edema, backflow of blood. The blood is not pumping. Your heart fails to pump, right? And you're going to have cold and clammy skin. Tamam. And of course, you're going to have ECG changes like STEMI, for example. Like, something that you need to keep in mind. In cardiogenic shock, it's not a problem with fluid. It's a problem. The heart is failing to pump the fluid. It's just the pathway is obstructed, So giving patients fluid is just only going to worsen their condition. So avoid aggressive volume of fluids. But how do we manage? Norepi. Norepinephrine is going to be your first line. You need to give them a vasopressor. That's number 1. Then, because the heart is failing to pump, we need to give it something to wake up. So we give it inotropes, and my favorite, and the one that you should be giving is dobutamine. Okay, works like magic. Then we need to be very careful with the fluid again. We do not want to worsen their pulmonary edema. And then we need to bring their mean arterial pressure up to 65. Okay. So this is how we hemodynamically and initially manage the patient. Definitive therapy is, of course, we want to treat the STEMI. So you need to do an emergency PCI, and you have the timing from door to balloon, insertion of the balloon, and freeing that the coronary blockade is up to 90 minutes. Okay, if they're having any sort of arrhythmia, you need to treat the arrhythmia. All right. And if it's refractory, then you need to, of course, bridge it to heart transplant evaluation. So you need to keep in mind early revascularization of the heart, either you do it with a PCI or CABG, will improve the 6-month and the 1-year survival in cardiogenic shock patients that's been complicated from acute MI. So my message from this slide, do not delay revascularization of the heart, because by the minute you're killing more and more cells and more tissue. Okay, so it's going to be more severely impacted if you delay treatment. Now, obstructive shock. Obstructive shock is basically you have an obstruction to blood flow. All right, where exactly? From the venous return or the right ventricular outflow. Usually due to pulmonary edema, pulmonary embolism. Okay, this is something that usually causes obstructive shock. So how does pulmonary embolism cause an obstructive shock? It will increase the pulmonary vascular resistance, and then it will cause this acute right ventricular dilation, all right, causing decrease in left ventricular filling, and blood is just going to start backing up. So you're going to have jugular venous distension. Okay, number one. You're going to have severe dyspnea. You're going to have pleuritic chest pain. Okay, so these are things you want to keep in mind. Cardiac tamponade is basically when you have this pericardial effusion, and basically it's blood building up in the pericardium. Is going to compress the cardiac chambers, all right, impairing diastolic filling. So the heart basically can't pump properly, and it's going to decrease your cardiac output. And you have this thing that we call Beck's triad, which is hypotension, muffled heart sounds, and JVD. And usually you have pulsus paradoxus of more than 10 millimeters of mercury. Then lastly, tension pneumothorax. Tension pneumothorax is basically when you have a puncture in the lung that basically will trap air in the pleural space, all right? And this will cause decrease in venous return, all right, and decrease in cardiac output. How will you know the patient's having tension pneumothorax? First of all, he's going to be unstable. He's going to be in respiratory distress, all right? And when you try to hear heart sound, breath sound, is going to be absent, okay? He's also going to have tracheal deviation, and he's going to be hypotensive, tamam? So this is how you know that he's having tension pneumothorax. These are the 3 top most common causes of obstructive shock. Okay, why you need to know the clinical signs? Because you need to be able to identify the scenarios when they're presented to you in the questions. Okay, how do we manage? So for every disease, we need to fix the obstruction. You need to clear out the obstruction. Okay, so giving a vasopressor alone will not resolve your obstructive shock. So what do we do? In massive PE, the first thing you want to do is that you need to give them systemic thrombolysis. And in this scenario, we can give them alteplase. This is your first line, okay? So that's something you want to know. We could also give them anticoagulants like IV heparin. And of course, we give them fluids and norepi. For cardiac tamponade, emergency pericardial synthesis. The best thing you can do is just remove the fluid from the pericardium. Tamam? That's number one. And of course, you give them fluid, mashi, and do not give them diuretics or vasodilators. It's only going to make it worse for them. Okay? Then we have tension pneumothorax. Tension pneumothorax, immediately you do a needle decompression in the second intercostal space, all right, in the midclavicular line. You do it immediately. Do not wait for imaging. So if they tell you, how would you manage? And in the question, they were like, so first get imaging, then decompress. No, you decompress, then do whatever. Always remember ABCs. You need to stabilize the patient first. Tamam? Then you do a chest tube thoracostomy and whatever. The most important thing you guys want to know is the order. طيب, needle decompression, then imaging. Okay. طيب. Now, sepsis, okay, which will lead us to distributive shock. How do I know the patient has sepsis? Because, let me tell you something. Sepsis is not something that you run a lab test for and خلاص, you'll know the patient is septic. Sepsis is a clinical diagnosis, all right? It's something that your judgment in the clinic is going to say that this patient actually has sepsis. So how do I know that patient has sepsis? First of all, he's going to have organ dysfunction, tamam, caused by a dysregulated host response to a certain infection. That's number one. How do I know he has organ dysfunction? He needs to have an acute increase of 2 or more points in the SOFA score. Okay, so he will have a persistent hypotension despite whatever vasopressors you give, whatever fluids you give, and their serum lactate is going to remain elevated despite all fluid resuscitation. This is the clinical way a patient is going to present with a septic shock. So persistent hypotension, no matter what you give them, even all the vasopressors you give, persistent hypotension, serum lactate is going to be elevated, and they're, no matter how much volume you give them, volume resuscitations, they always fail to improve. So that's septic shock. Like, now we have a SOFA score and we have a Q SOFA. So Q SOFA is like the quick SOFA you do in clinics. SOFA is the one that's like detailed that we've covered in part 1, where you have 6 organs. Each organ is scored out of 4, and it's a total of 24. If in general the SOFA score happens to be 2 or more, this indicates that we have organ dysfunction and we need to intervene immediately. Tamam? That's number 1. A Q SOFA is something that's done like fast. So it's a criteria of 3 things, and each has 1 point. So you have the respiratory rate being more than 22 breaths per minute. You have altered mental status. Okay, so you'll have the GCS score less than 15, and you'll have the systolic blood pressure less than 100. Now, something you guys want to understand, that Q SOFA, Mashi, is not used as a screening tool. However, it's used to stratify risk in bedside, in bedside scenarios. Okay, so it's not a diagnostic tool. It does not tell me the patient has sepsis. It will only tell me, Mashi, what's the risk for the patient developing sepsis. Okay. All right, so that's very important. They could trick you with an MCQ. Now, how does sepsis happen? First of all, you will have this inflammatory cascade. You'll have this cytokine storm. Again, TNF alpha, interleukin 1, interleukin 6. These are the players, right? They're going to go activate your complement, and then you're going to have this coagulation cascade activated. You have a lot of platelet aggregation. You're going to have this nitric oxide, being released like crazy, which is going to do what? The vasodilation. Hence, you're going to have distributive shock. Okay, so it will, of course, cause an organ dysfunction. Why? Because it's going to shunt the blood away from the capillaries, right? That's number 1. You're going to get microvascular thrombosis because of these platelets aggregated and these coagulation cascades being activated, right? And something that's unique, that you're giving them oxygen. Delivery of oxygen is adequate. However, oxygen extraction at the cellular level is what's affected. Hence, sepsis. Okay, so in the question, they might tell you that they're receiving oxygen and stuff, yet they're not responding to it. So this means that we're having impaired oxygen extraction at the cellular level. So if the patient is having tissue hypoxia, it's going to lead to what? It's going to lead to end organ damage. And if one organ gets damaged, another organ gets damaged, I will get multi-organ failure. And I'll go back all the way to multi-organ dysfunction. Okay? Remember that lecture? Happens exactly here. So how do I pick up sepsis? So if you look at this case, for example, we have a 72-year-old female, diabetic, in nursing home, feverish, 39.2, extremely high, confused, high rate, hypotensive, she's tachypnic, she has foul-smelling urine, her lactate is more than 2. That's concerning, right? This is fits septic shock, صح? So, and she's been given 2 liters of crystalloid with minimal BP improvement. Does she meet my septic shock criteria? Yes. I have suspected infection. طيب, she's clearly in organ dysfunction, given that her heart rate is high, she's hypotensive, and she's tachypneic. طيب, her lactate is high as well. And despite fluid resuscitation, she fails to improve. So yes, septic shock here is confirmed. Now, what am I going to do? I will immediately uh, provide antibiotics. Like, but of course, there's a ladder of things. But the minute you pick up septic shock, what do? First of all, you measure the lactate, blood culture, then immediately give antibiotics. Do not delay antibiotics at all. Within 1 hour, you need to finish these 5 things. Measure lactate, blood culture, broad spec of antibiotics, and then you need to resuscitate with fluid, of course. So you will give them lactate ringer, all right, if they were hypotensive or if their lactate levels were high. You give 30 milliliter per kilograms, and then you will give vasopressors if they're hypotensive persistent after the fluids. So you'll give norepi. Norepi is your first line. Why? Because you want to maintain the mean arterial pressure at 65 or above. طيب. Okay. So in this slide, first of all, you need to understand that you need to give them a lactate ringer, not a normal saline. Why not a normal saline? Why not? Because a normal saline is going to cause these patients hypercholoremic metabolic acidosis, and they're going to increase the risk of AKI. This patient is already, metabolic demands are failing to be met. So all these metabolites are being built up. They're having metabolic acidosis, they're having lactic acidosis. Giving normal saline is only going to aggravate the situation. So you do not give normal saline. And don't even think to yourself it's okay. You give balanced crystalloids lactate ringer. That's it. Mashi. So do not wait. Do not wait on giving fluids. Immediately give fluids. We could also do this passive leg raise to increase the blood pressure. Mashi. We reassess after each bolus. Mashi. If there's no response, you could stop. Now, do not give albumin routinely for any initial resuscitation. Remember, you only give albumin when genuinely the patient, for example, the patient is having burns or the patient has some sort of cirrhosis, right? That's when you will actually go in and give albumin. But not every septic shock patient, khalas, I'm going to go and hand them albumin. You do not do that. This is very important that you know. You also need to avoid hydroxyethyl starches, which will increase AKI and mortality risk. It's in the slides. I don't know what it is. And you need to avoid gelatin solutions, and you need to avoid fluid overload. You don't just pump the patient on fluids, just khalas, so that he will become better. You do not do that. There's a rate that you follow of 30 milliliter per kilograms within the first 3 hours of a septic patient who has hyperperfusion and hypotension, but you do not pump them on fluids because this will increase the risk of morbidity and mortality. Very important. Now, vasopressors and inotropes in septic shock. First line vasopressor for any septic shock is norepi. Do not wait on fluids. Immediately give norepi. That's something you guys want to know. That's number one. Okay. Then you have dobutamine. Dobutamine, yeah. Oh, actually, let's go through all of them. Vasopressin. You will give vasopressin when you're giving norepi and escalating the dose of norepi. Dobutamine, again, you'll give it. It's an inotrope. When will you give it? When you have this persistent hypoperfusion despite fluid and vasopressor. So if the question tells you that, all right, we have this patient who is hyperperfused and we've given them fluids, we've given them vasopressors, still not working. So now you're gonna think that it's not his vessels, it's his heart that's failing to pump. He's having some sort of cardiac dysfunction. So what are you gonna do? You're gonna give them dobutamine, an inotrope, so it wakes up the heart and tells them, yalla, you have something to do. You have blood to pump. All right. Epinephrine is just like norepi, mashi. So it's alternative. However, why do we prefer norepi? Because norepi does not raise your lactate. Epinephrine raises your lactate, and it's a bit of a confounding factor here because people who have septic shock already, they have lactate levels really high. So if a question comes, norepi or epi, of course norepi. However, in the choices, if epinephrine was there, and you need to give a vasopressor, you're going to give epi. Dopamine. We don't give dopamine in septic shock. Why? There's no point for the patient to feel happy. Don't give dopamine, okay? Why? Because it will cause the patient to be at a higher risk for arrhythmias. So we do not give them dopamines, okay? Hydrocortisone, yani we do give it when the patient is refractory to both fluids and vasopressors, okay? So when they're failing their initial resuscitation, yes, you do give hydrocortisone, okay? So again, when you need to monitor the patient, you need to serially monitor them. Remember when we were talking about the SOFA score in the first lecture, one score is not really gonna direct me in any path. All right. However, what I need to do is I need to get serial measurements. Why? Because it's going to tell me if I'm doing something right or not. So for lactate monitoring, you have to monitor the lactate, across different timing, طيب, because persistent elevation means that there's hypoperfusion still going on, which will basically tell me that the patient is getting probably a higher SOFA score. There's a higher risk of organ dysfunction. All right. You need to monitor the main arterial pressure. Their urine output has to be more than 0.5 milliliters per kilogram per hour. You need to see that their mental status is improving, all right? Their temperature and the color of the skin is better, right? Because we said most of the sharks will have cold and clammy skin. Distributive is going to have warm. So you want to assess that as well. Okay. And of course, there are some imagings and labs you have to do just to make sure that you do not miss anything from the whole picture. All right. And that's it. Thank you so much for attending, first of all. And coming from someone who just graduated, I want to say congratulations. This is the last exam of your preclinical years. And clinical years are going to be fun. Your guys are going to love it. Enjoy every bit of it, the stress, the jokes, the clinics, the lectures, the memories you get to do with your friends. I wish you nothing but the best. If you ever need anything, any sort of help, any sort of guidance, I'm always available. That's my number, that's my email. Thank you so much. Don't forget to scan the QR code. There are some practice questions that's been there for you to solve. And I'm looking forward to hear your feedback. Thank you so much.